Good morning. We're going to test this mic. 1, 2, 3. 1, 2, 3. Now we're not. We're not mute right now. Can you hear me? Oh, yeah. Can you hear me very well now? Yeah. You want to pump up the volume a bit? Yeah. You may have. Sorry? Oh, you got it off?
I don't think this will change it either. Test 1, 2, 1, 2.
We're testing the volume here. Oh, yeah. Yeah, that's good. Yeah, so keep it. Maybe I can adjust it. Yeah. How's this volume here? That looks pretty good. That looks pretty good. Okay. Okay, good morning. Can everyone hear me okay? I'll just put the volume up a bit here. Is that, can everyone hear quite well? Good morning. Uh, Good morning. Welcome to the annual Healthcare Talks, our fifth annual symposium. And I'd like to welcome back some of the audience members that have been with us over the last few years, and also some of the newer members in the audience. We've planned a great day for you today. And just as a reminder, if you could silence your phones. I've already heard a few go off. Um, my name is Dr. George Freybeck. I'd like to just introduce myself. I'm a urologist here at Abbotsford Regional Hospital. I've been here since 2004. I started my training at the University of Pennsylvania. I was raised in Vancouver, went to the States for my undergrad, did my medical training at UBC, residency in urology at UBC. Oh, sorry. And after I did my training at UBC, I went to Austria for a one-year fellowship in minimally invasive surgery. And then I got a job here in Abbotsford. And about 3 years ago, I joined the foundation as a trustee member. So it's a privilege for me to work at ARH and be a member of the foundation and see you all here today. So this is a really unique date or presentation today because of the world events, i.e. COVID. And so what we're doing is a combination of this forum with those of you in person, and then we also have the audience at home isolating, and they'll be receiving this as a digital stream in real time. And likewise, our speakers are going to be a combination. Most of the speakers will be here on site, and then there'll be two speakers that will be streaming in from home. So regardless of where the speakers are, where the audience members are, we hope to have a lively presentation, interactive. We'll have some questions at the end of some time for questions at the end of every presentation that you can ask questions to here and at home. And we've chosen the talks to be as relevant as possible and impactful with current events. And this was sort of a brainchild, and the purpose of these talks is really to give, as a way of us giving back to the community and to showcase the excellent work that's being done by the Abbotsford Hospital and the Cancer Agency. And it's a privilege for me to be part of this because as a doctor, I'm always looking at ways to showcase some of the newer treatments that we have, some of the advances, but also some of the challenges. Because we see patients individually, but we don't have too many opportunities to expand that platform to a greater society. And then the second reason it's a privilege is because as a member of the foundation, it's a way to give back to our supporters who have given and continue to give and support us. So this year, our lineup of speakers, and if you look at our agenda, it has no doubt been influenced by current events, globally, geopolitically. So nationally, we've had the legalization of marijuana. So we have a talk on on marijuana and specifically medicinal cannabis, which was legalized last year. And Canada actually, if you know, 20 years ago, was one of the first nations to credentialize a cannabinoid extract for wasting and pain. So Dr. Pippa Hawley, who is a professor at UBC, will be speaking on that. And internationally, the pandemic, the COVID-19 pandemic, as you know, has influenced everybody and affected everybody, and it has massively disrupted medicine. And as one of the largest draws of our GDP, you know, this has changed everyone's lives, both physicians, nurses, healthcare administrators, and so forth. So we'll be talking about pandemics and COVID specifically with Dr. Henni, who's one of our infectious disease specialists. And as a sequelae to this, we'll be going into digital medicine and telehealth with several speeches on how to bring medicine into the modern age with technology and get the medicine into your home, both for monitoring and hopefully eventually for treatment and care. So I'm excited for today. It should be a banger. And next, I'd like to introduce our executive director from the foundation, Liz Harris, who is a distinguished alumni from the UFV and has studied there in BCIT. She's worked for many different nonprofits and very influential in our business and nonprofit community. And she'd like to say a few words before we get going. Liz? Yeah.
So good morning, everyone. I'm not as tall as George. So normally I always say I'm always great to be here and see everyone, but I'm actually extra excited to see many of you because once the hospital kind of closed down and things shut down in March, I haven't seen a lot of you, and I usually pop up at meetings or I have coffee with you, or we chat or everything, and a few of you I've chatted on the phone, but it's extra nice to see so many of you here. And we had a staff meeting in this room the other day, and we actually sat like this as well too. We felt a little bit like we were at school at Snoopy, and we were all lined up at the board, and the teacher was up at the front when we were having a regular meeting. So we're just kind of adjusting to ways of life, and it's nice that we can still hold today and then also hold it virtually. So your other viewers are maybe in their jammies having a little cup of coffee while they're watching us, but it's nice that we can actually reach everyone in a different way and still to communicate with everyone. So I am extremely excited to see so many of you. But as George says, my name is Liz Harris. I am the executive director of the Fraser Valley Healthcare Foundation. I can't believe this is our 5th health talk since I've been here. This is actually my 5th year with the foundation as well too. I have a few little housekeeping details for you as well too. If you need to use the washroom, you just go out the door, and where the desk is where you checked in, there is washrooms there. With the ladies' washrooms, there is 3 stalls in there, so just be aware when you go into that washroom. I don't know what's in the men's, so you'll have to discover that on your own. And if those washrooms are full, if you go down past the Starbucks, there are some more washrooms there as well too. So we can find some as well too, just so we don't get all the crowding as well too. We do encourage you to also wear your mask as well too when you can, and practice social distancing. Lunch will be served in the hall, and if you're like me, you're already thinking about lunch because I'm always hungry and always want some snacks. And as George says, you have some fantastic speakers today, and fantastic we can have some of them here in person, and then also to have some of them virtually as well too. Cheryl Beach is going to do hers virtually, so you really have a fantastic day. So. And we're blessed to have Dr. George Raybeck on our board and to actually be a part of our health talks and help coordinate this day and help us get all these wonderful speakers to share and connect community with the hospital, so we learn more and more about what's going on. And then also too, this event wouldn't be possible without some of our sponsors. So Abbotsford Division of Family Practice, Shoppers Drug Mart, Trillium Bevan Village, and also too, Health Talks was originally formulated by one of our board members, Dr. Peter Fry. So he had a vision of putting on this event. So he actually helped with the first one, and then we've been able to grow it every year, so which is fantastic. Okay, now we're going to try my presentation. Here we go. So as you know, Fraser Valley Healthcare Foundation, we are the fundraising arm for the 4 hospitals here within Fraser Valley East. So Abbotsford Regional Hospital, Mission Memorial Hospital, Chilliwack General Hospital, and Fraser Canyon Hospital. Okay, I'm just pointing this at air and it's clicking, so we're doing really quite well this morning. So here are some projects that we are currently in the process of raising funds for. We're a little behind in our funding just because we ended up having to change some of our direction, and we did a lot of funding for COVID this year. I have a great supply of iPads that I've actually bought because, as you know, many of you can't enter in the hospital and you have loved ones in here. So we actually ended up, I think we've bought about 200 iPads so the nurses can use them as communication tools with their patients, once for either translation or the other piece so they can actually communicate with their families at home. So we've been really trying to embrace technology. But we are raising money for the emergency department expansion here on Abbotsford. It is on track, so it'll be exciting to see some new pictures when it comes. Chilliwack, we're looking for a radiographic fluoroscopy machine as well too. Mission, the lovely Mission Auxiliary ladies, they were turning 100 years in March. They didn't quite get the birthday they were hoping to, but with some other community groups, they are raising funds to purchase lab equipment. That lab equipment's actually all been ordered and is there working except for 3 pieces of equipment. So it's good to have that great technology. And then in Fraser Canyon Hospital, the Neuroscope and ER stretcher beds we're purchasing as well too. So I'm going to show you a little video. This is Neil, an ICU nurse here at Abbotsford Regional Hospital who did get COVID. He is going to share his story with us. I have arms, no video. Oh, will it work or not? We don't have to video. We might be able to video. Where is he going? Oh, I'm gone. And also too, when you used to go to the hospital too, a lot of our auxiliary gift shops are currently closed, but some of them are slowly starting to open up. So make sure as well as you kind of check those out, because, you know, those dollars, like Abbotsford's gift shop has reopened up, those dollars go to support the ER department. You know, in Mission, they supported the lab. So just keep those in mind if you're out doing a little Christmas shopping or something, and start to visit our, you know, our lovely auxiliary ladies in the community, because they're trying to figure out and adjust to the wonderful world of COVID.
Towards the middle of the peak of pandemic in the hospital, I felt ill. I had persistent high temperature, which I thought is very common to our COVID patients. So that's when I realized that something is wrong with me. So I asked my wife to take me to the emergency room. I stayed in ER for a night. And I said to the doctor, maybe I need to stay here while I'm waiting for the swab test result. My doctors in the intensive care unit are willing to take me upstairs to stay there for a bit.
When I first heard that he was sick, I was on evening shift and he was in room 19, and I went in and just kind of talked with him at the door, and he looked scared. And that really, really got me. Like, I was like, holy crap, like now it's at home.
A few days down the road, my breathing is now begin to be affected. From there on, I have an intermittent recollection of what happened.
He was on a little bit of oxygen, but he was really struggling, and I could see the fear, and I knew that he was going to need to get intubated. And it was really hard to see that.
I think he came in, what was that, Thursday night maybe, and by Friday night he was on the vent, I think, and then on Saturday we had turned him on his stomach already. And it's so scary because when they turn somebody on their stomach, that's just the last ditch effort. And I was just like, oh my God, I can't believe Neil's on his stomach.
He was ventilated, right? He was completely sedated and on very, very high doses of the sedative, the anesthesia. And so seeing Neil like that was tough.
I think I was tubed for 10 days. I was on a very uncharted territory. It's really hard to relive the moment because I thought I'm not gonna make it anymore. Well, not that I realize I'm vented or lying down on the bed, but obviously my family would be very devastated if that thing happened because I don't feel anything anymore.
So everybody was getting burned out. And then on top of that, now we have this emotional challenge.
You know, we automatically go to the worst case scenario because we've seen the worst case scenario. And when it's one of your own, you worry even more.
He was like so close to, one of us as a group, and here it's like one fine line and he's on the other side.
It really personalized it. It made COVID real to see how sick he was. And I'm just grateful that he's here today.
I always told myself that I'm the unlucky and lucky one, unfortunate and fortunate one, because they've managed to take me back. That's why I'm here, talking to you, So I would like to take this opportunity to thank everyone. They really did a wonderful job, excellent job. They go beyond and above. Their dedications to their job is what made me able to get out of my critical situation and get me back to life. That's why I'm here.
I was there on the day that he was discharged. We were all so proud of him and so happy. It was like a very rewarding and honoring time.
I think in a way, as much as it's such a crisis for our unit to go through, I think it all brought us together. I've always believed in our team. My coworkers are not just my coworkers, they're my critical care family.
We're here to save lives, and we can mitigate people from coming to the hospital if they do their share and part of it. Rest assured that the hospital and the community are doing its best to be able to mitigate this thing from going any worse. We are all in this together, and we should be out of this pandemic altogether too.
So that's Neil, a nurse from our ICU, and I actually got to meet Neil and all of the ICU staff, and they shared their story. And I think all of us, healthcare workers we're all adjusting to something different. And people ask us, "Oh, what should you do?" We're kind of all learning as we go, kind of thing, and how to tackle everything. But Neil is managing as well as he can at this time, and the staff are, working quite hard, and the community has been so grateful to support all of the healthcare workers and the police and everybody working and trying to help make sure we're all okay. So, and if you ever want to share that video with anybody, you can just go to our YouTube channel on Fraser Valley Healthcare Foundation, and you can find the video there as well too. So I just would like to say thank you for coming again. I'm going to leave you in the hands of Dr. George Raybeck. He's going to moderate the forum today. I know that George gave you a little bit about himself, but just so you know that he's been in the community here in Abbotsford since 2004, was fortunate to be involved in the move from MSA to ARH Hospital. He remains active in clinical research, primary and prostate cancer. Dr. Raybeck, as you know, always serves on the foundation board as well too. So he is working very busily within the community and also supporting the community in different ways as well too. So we're grateful to have him here with us today. So please enjoy your day, and I look forward to connecting with all of you guys. Thanks.
Okay, our first speaker, I've known for many years since coming to Abbotsford, Johnathan Burns. He's a family physician who has been involved with the wide spectrum of medical care in our community. He's done emergency medicine for 16 years. He now does a lot of hospice work and runs the quality initiative program for the hospice group in the hospital. He's a board director at the Division of Family Practice, and he's going to be speaking today to us about in-person virtual care and different ways to access your family doctor. So welcome, Dr. Burns.
Thank you, Dr. Raybeck. Thank you all for having me here. I don't come with all the answers, but we can work together, and happy to take questions at the end. COVID, first let me ask, who here has not been impacted by COVID-19? Not getting the disease, but your life. I think we've all been affected, would you agree? And so now what we're seeing is George, it doesn't seem to, there we go, okay. So now what we're seeing is that impact is coming into how we deliver care and how we serve you as patients. And I think you've probably all been evident of that, of trying to get in to see us or trying to access care. It's been a very monumental shift in medicine. And I think that a lot of these changes will have the potential to become permanent. When we think about how our systems work, medicine has been very lucky to have had little impact from IT over the years. When you think of how we used to get videos, I tell my kids about how we go down and walk up and down the aisles and look at things and then get them and then freak out the next day when we forgot to turn them back. Now we're Netflix. Now, and medicine, I think, is probably going to be going the same way. This will become part of how we deliver care moving forward. So we better get used to it. We still are seeing patients. I still am seeing patients every day. Probably 90% or more is on the phone or video. We do still screen people and then see them live. And as you know, our ER is open, radiology is open, surgeries are open, specialists' offices are still open. So we're delivering care, it's just different. There, yeah, okay. It's not on this. Do you have a copy of it? So it's not going through? Okay. Thank you. Said George, always have a backup. Thank you. Okay, so family doctor. So the family doctor, obviously you have a relationship with them, and that's probably the single most important factor. Their office is the good place to start. So we have a process of how to see patients during COVID. We have all our technology is up to date with both video and phone and booking online. So the main ways we do this right now is, as I said, phone, Zoom, video conferencing, some texting, some email, but that has some issues because when you send an email to someone, you don't know whether they're ever going to get it. And then if one person assumes they've got the email, but the other one never got it, trouble can arise. So right now, email is still not a very big way of practicing, and it has some privacy concerns as well. So what we do in our office now is that before we ask you to come in after we talk to you, we pre-screen. So do you have any symptoms of COVID? Have you been unwell? This is going to become really challenging. The summer's been great, but this is going to become really challenging this fall when our friend influenza arrives. And everyone will assume that you have COVID when you most likely have influenza. It's going to be a real big problem, and I don't know, we'll have to just take that one day by day. Everyone here knows about Medimap. So it's a resource online, medimap.ca, and you can look at in real time what the wait times are at walk-in clinics. Next slide. Next one. Next slide. So if you feel it's something that needs to be seen, then give us a call and we will screen you and book a time to arrange a virtual visit. We're doing that now, and I think most of the other clinics in town are. Next slide. When you show up, we will check your temperature, and masks and gloves must be worn. I will warn you, it will be slower, it will be frustrating, and it will be cumbersome. We have had already in our office multiple threats of violence from people not wanting to wear masks. It just astounds me. But it's happening. I've seen it live with my own eyes. We had to phone the police last week because someone was threatening to drive a truck through the door because he would not put his mask on. So we, as physicians, also run a business and we have to protect our staff. So we cannot have our staff at risk because of just, doing the right thing, but also from a WCB standpoint as well. Next slide. So there's probably a lot of concerns that people have. I mean, you're used to doing things a certain way, and now here we are saying, let's do it differently. So is the care safe and effective? There was a big study that just got released last week out of McGill, and it showed that online care was 77% as effective. So it's not bad. It's not bad. I had a lady of mine, a very dear lady, who the family phoned me about 3 weeks ago, and they said, Dr. Burns, her knee is just killing her. She fell. So I said, look, show me a picture of the knee, and it looked like there was a little excoriation on it. I said, move the knee. The knee was moving okay. So I thought, fine, we'll just give her some Tylenol and let's see how it goes. A few days later, no, still can't walk. So we sent her to X-ray. Knee X-ray was perfect. 2 days later, knee is still really, really sore. I said, well, you better take her into the hospital. So in she went, and she had a broken hip. So nothing is perfect. And so it's just that we have to keep doing what we're doing and keep at it, keep reassessing. If you're not happy with something, phone back. We will help you. Is the systems that we use secure? Email has questions. Zoom is for sure. Direct phone is safe and secure. Very hard to hack. And I think the technology is pretty good right now. And I have a lot of I have a very, very delightfully elderly patient population. And I'm amazed at how they're using the technology better than some of the young people. They're probably not as quick on their phones, but on the computer, they're rock stars. So it hasn't been an impact in terms of, I can't access you. We haven't seen that yet. And we can always just use the phone and the people that won't use a computer. Next slide. So just ask yourself some thoughts before you enter into the system. Is my need today episodic or chronic? And so chronic is something that the disease we are treating, but we're not curing. And do you need to be seen immediately, or can it wait a little bit? And I think one of the big things is try to think about med renewals in advance. So not go to the cupboard and think, I have one pill left, because that creates a lot of chaos on everyone's part. And there's ways that we can mitigate that in advance. Plan your lab tests for chronic diseases, re-referrals for your specialists. When you do access the care, please find a private, quiet place that you're comfortable and you're not feeling threatened or rushed by the environment that you're in. We know that lists are the common way of interacting, but with a time frame, just be careful that you don't add too many things to that list, because what will happen is then you will get little bits covered of every little thing. And so I would advise picking your top things that are concerning you and making sure you get direction and answers on those. Next one, please. So here are some that I've seen are good things that we can deal with on telehealth. So mental health, skin problems, we can have photos sent by various apps on the phone or computer that are safe. Urinary tract symptoms without any fever or pain. And then any other general questions and chronic disease management. Next. one thing that medicine will never change is the hand-on care and the examination of the patients. So we have to not be treating chest pain, shortness of breath, acute loss of vision, these things. And I think everyone would agree with these, but I just thought I would put them down for completeness. Next. So we have information in our community and from our division. Next. And I love Dr. Henry's thing here. I think that still is here in the lounge this morning where they were talking, and we have our first COVID intubated for the first time in probably 7 or 8 weeks. So the second wave is potentially starting. So we still have to remain kind, calm, and be safe. And I think, do our distancing, wash our hands, wear our masks. So any questions from anyone? Yes. Good question. That's about me. Yeah. I don't think you can, because if you look at the data now, most young people that are getting it are asymptomatic. I had a positive COVID screen on Tuesday this week, and I phoned the guy, and I could hear this huffing and puffing. I thought, well, what's going on? He goes, oh, I'm out running. Positive COVID. So, it's a very good question. It affects everyone so differently, and we just have no way of predicting.
So that's why it's so important to put on a mask.
Right. Assume everyone has it outside of your bubble. Assume they all have it. And just treat accordingly. So if I had it now and you stay this far from me, and you wear your mask and I wear mine, very low risk that you'll catch it from me. But if you sit across from me and I cough near you or touch stuff and then you touch your eyes, very high chance you will get it. And I think just keep it that simple.
So 6 feet or more?
Right.
At least?
Yes. Okay, thank you all very much.
Thank you, Dr. Burns. Our next speaker is Cheryl Beach. She's going to be streaming in, and she's the Executive Director for Integrated Community Services, including home health and home support and palliative care at Fraser Health. She's worked nationally and internationally within healthcare for the last 25 years in a variety of positions, including as a clinical physiotherapist. And she's very passionate about innovative approaches that can improve quality and efficiency across the continuum of healthcare. So welcome, Cheryl. She's going to, Cheryl will be speaking on remote monitoring and opportunities for virtual care. Welcome, Cheryl.
Great. Thanks, everyone. Can you hear me there?
Yes.
Yeah, okay, great. And the slides are up. So I thought sort of befitting that I'm talking about virtual care opportunities in the community and be part of this talk virtually. So thanks for everyone for making that happen. And I do apologize, I can't see the people in the room, but I do look forward to questions at the end of the presentation if you do have some. Next slide, please. So a little bit of overview. What I'll talk about today is I'm going to talk about some new services that we have in the community within Fraser Health. And then I'll talk a little bit about how we're doing things a little bit differently in the community with this philosophy of the Virtual First Foundation so that we can ensure that we're keeping all of our patients, our clients, and our staff safe. Next slide. So new service that we started early in the pandemic is remote monitoring for COVID-19 patients. And this is a service where a patient is in their own home, has been diagnosed with COVID-19 or suspected of having COVID-19, and they can be monitored remotely by a Fraser Health nurse or respiratory therapist. And the patient basically downloads an app on their phone or their tablet, and every day they answer symptom-related questions, and those questions then can be reviewed by the nurse who's in the office, and we'll follow up with the patient based on the responses that the patient provides. Next slide. So who is this service for? It is for adults over the age of 19. As I said previously, for those who have COVID or highly suspected of having COVID. It is to support those patients that might have more complex medical needs or be at high risk of COVID-related symptoms or they're frail. So as we heard earlier, it's not required for those that have very mild symptoms, and sometimes we don't know what the progress will look like. And the patient needs to be willing to work with the nurse or the respiratory therapist. They don't have to have a tablet or a smartphone. We can also provide the service simply over the phone, and the nurse will ask the questions over the phone if the patient doesn't have the technology. Next slide. And how do we access this service? Most physicians have been aware of this service, that the information is provided through the Division of Family Practice, so patients can talk to their doctor about the service. They also can call the home health service line if they feel that they are in need of this service. And we do have information on our website if people are interested for more information around that. And next slide. Fraser Health has also just launched a new virtual care service. This is for anyone in the Fraser Health region, and it's a safe way to access healthcare advice. It's a 1-800 number on the slide. It's open from 10 a.m. to 10 p.m. 7 days a week. It provides you direct access to a nurse within Fraser Health who can help advise you on whatever symptoms or concerns you may have, and they can help to really connect you to the right service. So that right service might be a connection with your family physician, it may be a connection with another Fraser Health service. So if you're not sure where to find service with a health concern that you have, you can call this number. And it may be a little more helpful than calling 811 just because the nurse has better access to Fraser Health specific services, and so we can get you the care you need as quickly as possible. Next slide. Many of you may know that early in the pandemic in March, the Ministry of Health advised all health authorities that we would to be closing our day programs for older adults. We now are at a stage where we are reopening certain of those adult day programs in a phased approach, again, to ensure that our clientele are kept safe. And at the same time, we're also delivering virtual day programs for older adults. We are reaching out to clients and caregivers. We are expanding this service to support people in their home and keep them socially engaged and active as possible, but also keeping them safe from congregate settings. Next slide. We're also embracing the Virtual First Foundation within home health services. So if some of you or your family do receive home care or home care nursing or physio or OT, you may be asked if a virtual visit is appropriate. And those virtual visits can be conducted via Zoom, FaceTime, or WhatsApp. And we have had some really good success with this. It's not a large percentage of how we're doing visits, but as we move forward through the pandemic, we may be using this more frequently, and we may be asking clients and family members to support this in order to keep everyone safe. Next slide. We are working within our services to provide consults virtually. So under the home support services, a community health worker who may be in the home with a client, they can connect virtually with their nursing supervisor. They can use their phone. They can have a video connection. And again, to really provide timely and good care services to our clients. Similarly, a community health nurse may access a palliative clinician or a physician while they're in the home virtually, again, to help with our timely and safe access to care. Next slide. We also have started a launch with virtual care conferences. So we, as a healthcare team, have worked interdisciplinary and done case conferences for years. Now we're now working on how we can best provide those care conferences through virtual connections like Skype, Zoom, or Microsoft Teams. So we're really continuing to benefit from an interdisciplinary team approach, but we're using the technology, and many of us are learning how to best use this in a variety of communities. We are including family physicians when available for the team discussions. We look at complex clients who are in the community, as well as patients who may be in the hospital and require extra planning for their discharge. Next slide. I think in terms of what's next, we continue to be committed to explore new ways that we can provide care virtually safely and effectively. So I think we will continue to see new initiatives and exciting new things in this area. Next slide. And so I'm open to questions that anyone may have. Thank you.
Any questions for Cheryl? Cheryl, I had a question. Where do you see all this going? If you can catapult us into the future, what's on the horizon?
Yeah, that's a really great question. I have a special interest in monitoring technologies in the home. And we're looking in Fraser Health potentially to do some pilots around that. So how can we, for example, use things like motion sensors and contact centers to really use technology to better support our patients and clients? I have personally used this kind of technology with my mother, who has dementia and lived in Northern Ontario. And I think there are huge opportunities for us in the community to really leverage technologies that are out there to support the care for our clients and provide a better choice for people to stay at home and potentially avoid transitions to long-term care, for example, or prevent admissions to hospital.
And just to follow up to that, would this be something like the hardware, the technology, would that be something that the health authority would provide? And if so, how would you deal with, say, confidentiality? So third parties aren't seeing how many times you're getting up as a urologist, how many times you're getting up to the bathroom, and then it would alert them, hey, this fellow's up 5 times tonight. He's got a pee problem.
Yeah, that's a great question. So in terms of the health authority paying, we are exploring those potential options right now. I have a team together. We're looking into that, and in terms of what kind of criteria we would have for that. So we are exploring that right now to see what is feasible from the health authority side. You're exactly right. The watching how much a person is up at night, out of bed, potentially, wandering around the house or going to the bathroom is clinically certainly something that we want to understand because we know it has such an impact, especially if someone has a mild dementia. Most of these platforms have, in Fraser Health, we do what's called a privacy impact assessment and also a safety threat risk assessment, the STRAW. So when we look at using any kind of these technologies, we do a review that is guided by our provincial guidelines in terms of understanding where the data the pathways of the data, right? Where is all that data going? Who has access to it? And what is the potential risk of being hacked into? So when we look at using a system in Fraser Health, we go through those processes with our privacy and our security people.
Yeah, go ahead. We have a question from the audience.
Okay.
Hi, thanks for your talk. It's very interesting, the techniques that are being explored. I just wondered if you knew what is happening in some of the other health authorities. Are they at the same place with you, with Fraser Health, or are they behind or ahead, that sort of thing?
Yeah, that's a great question. I do have monthly meetings with the other health authorities. The example of the remote monitoring service for COVID-19, I know Island Health also provides that service, for example. The use of virtual platforms and connecting in with clients and families, the other health authorities are also looking at expanding and you know, how do we do that safely and effectively to ensure that we're providing the care in the home that's required, but you know, when there is an opportunity to do things virtually. I think Northern Health, for example, is very interested in this kind of technology because they have the very rural and remote challenges that we on the mainland and Fraser Health have less of, although we do have certainly rural and remote challenges out towards Hope. So I try to stay connected and we try to learn from each other across the other health authorities in what types of services we're delivering and how we do that.
Yeah, I would just like to follow up on that point, Cheryl. Being in Canada, we're so spread apart. From a cancer care perspective, there's always been a challenge in the more rural communities, such as in Northern Health, to get cancer care to those patients. So we have had satellites, family doctors becoming sort of a local oncology type, playing an oncology type role to have a reach out and provide that cancer care that for those patients that can't come to an agency like we have here in Abbotsford. So it sounds like the pandemic has really just pushed us forward because we're all isolating at home. Even in an urban center, we're kind of apart. So that's where that theme, I guess, is coming into.
Great. Yeah.
Any more questions for Cheryl? Okay. Okay. Thank you very much,
Okay.
Cheryl.
Thank you.
Yeah, we're running a little ahead right now, so we'll take a 10-minute break and wait for our next speaker to arrive. Thank you.
Yeah, me too.
Do my walking and I do chores and things, and then you go to get up. Give on where you go.
First thing in the morning, I need this first start.
Oh, hi, good to see you.
Surrey. Yes, last year was at Surrey. I never even thought that it would be somewhere different.
And it's funny because I don't remember going to Surrey. The ones that I have been to have been Hawley and out on the highway by Castle Fun Park.
For some reason, I thought it was Surrey I went to last year, obviously not. But yeah, I got up real early. I was on the road by 7.
Oh my God.
All the way way to Surrey, and they're telling me there's no conference. I'm going, what do you mean there's no conference? Anyway, so I put into my emails and found one that said, would be here, and I just, I wanted to just go home and back to bed.
Yeah, I would have. Yeah, for sure. Wow, that's amazing.
Yeah.
I thought Alice was coming too.
Oh, really?
Well, because she emailed me and said, I'm waffling about whether I'm going. This is Landy and Linda and I are going. And so I didn't know who else was coming. There's 7 or 6 of us.
Yeah, a lot of us jumped on it as soon as I saw the email.
Oh, absolutely, we did too, because we knew that it was going to be very limited.
There should have been other people that wanted to come in person.
Oh, well. Oh, well. So, yeah,
I just, you know, I
That's a lot
sometimes
to
don't know where
drive.
my
Drive all the way up.
You got that?
Well, yeah.
morning. Can I have everyone back, please? And we'll close the doors at the back. Good morning. Okay, so our next speaker is Dr. Amina Henni. She's one of our infectious disease specialists. She'll be talking about pandemics, viral pandemics, with a focus on COVID-19. She's from Prairie Land. She's did her undergrad. She grew up in Saskatchewan, did her internal medicine specialty training in Edmonton, Alberta, and has been at Abbotsford Regional Hospital now for how many years? 1 year. Okay, so welcome, Dr. Henni.
Thank you. All right, so I know that many of you, I'm sure, are experiencing COVID fatigue and information overload. And so I'm not here to kind of reiterate what public health has said, because I'm not a public health official, but I thought I would talk about previous pandemics and what we have seen with previous pandemics and how they differ with the current COVID-19 pandemic, as well as maybe a little bit about the vaccine development process as we kind of near the stages where we might be hearing a little bit more about it, and talking about the normal vaccine development process and what has changed with respect to this COVID-19 vaccine. Do I advance the slides? Sorry. Okay, there we go. All right, so what is a pandemic and how does it occur? So pandemic is a global outbreak of an infectious disease. It doesn't have to be viral, but it often is. An example of a non-viral pandemic that has been experienced in the past was the plague. In order for a pandemic to occur, there has to be a new strain of disease. So whether it be influenza or coronavirus. And because it's a new virus, very few people within the population have any pre-existing immunity. So what that means is it can then spread very easily from person to person, and if it's not contained, can then spread worldwide. All right, so one of the viruses that's been implicated in pandemics is influenza. So I thought I'd talk a little bit about influenza since we're coming up on our flu season. So there's 4 types of influenza viruses, A through D, but influenza A and B are the ones involved in what we call our flu season. So these circulate seasonally. And influenza A virus is the only one that's been known to cause pandemics. For example, in 1918 and in 2009. Now, influenza A virus is split into different subtypes. So it has 2 types of protein on the surface. These are labeled H and N. And each protein has different types, different subtypes. Protein H has 1 to 18 and protein N has 1 to 11. And so as a result, you get rearrangement of these subtypes to result in different types of viruses. So when you hear H1N1, that's what it's talking about, the H and the N subtype on the influenza virus. So you can have a large number of subtype rearrangements, but the 3 major ones that routinely circulate, meaning we see within our flu season, are H1N1, H2N2, and H3N2. So how does the influenza virus change? There's 2 main ways. They're called antigenic drift and antigenic shift. So antigenic drift is when those H and N proteins change very, very slightly. So it's still the same influenza virus, but a little bit of a change in the gene. And this is the reason why the influenza vaccine has to be updated every year and why you can actually get the flu more than once. So for example, for other viruses like chickenpox, once you get it, you're immune to it because it doesn't change very much. The influenza changes ever so slightly so that your body can't be fully immune from the virus. Now, antigenic shift is when there's major abrupt changes in the genes of the H and N protein. And this can happen in various ways, including when a virus in the animal population gains its ability to infect humans. And that can result in a new virus, which, as we recall, is one of the criteria that you need to develop a pandemic. So for the 1918 H1N1 influenza pandemic, a new virus emerged during World War I, and they did a lot of studies back into its origin, and it's thought to have developed from an avian precursor virus, so a virus that was in the bird population that then adapted the ability to spread to humans. Humans, in turn, then actually spread it to the swine population, so the influenza virus continues to circulate within the swine population. During the 1918 pandemic, it resulted in 3 waves in the spring of 1918, fall of 1918, and spring of 1919. And the second wave at that time was the most severe. It was the most severe pandemic in history, and it occurred during the pre-antibiotic era. So a lot of people who develop significant viral infections, they're prone to getting a secondary bacterial infection. And nowadays we have antibiotics that can treat that, but back then there wasn't any antibiotics to be able to treat bacterial infections, so a lot of people died as a result, and a lot of people healthy died. A lot of healthy people died. Now in 2009, there were also 2 other influenza pandemics that occurred in the 1950s and 60s, but they weren't as severe. So our next significant pandemic occurred in 2009, which was once again a result of the H1N1 virus that was different from the circulating strains. But in this case, 30% of adults over 65 actually had immunity to the virus, likely due to its similarity with a strain that circulated in the remote past. So as a result, the elder population was actually protected, and so 80% of people who died were actually under the age of 65, which is unusual for influenza virus. In this case, there were 2 waves of infection that peaked in June of 2009 and November of 2009. And then this strain of influenza continues to circulate seasonally. So it's still within the influenza season, and it's included in our influenza vaccine this year. Now, coronaviruses is a family of virus that causes mostly respiratory tract infections, including the common cold. Various strains of coronaviruses circulate amongst animals and humans. And one of the major outbreaks caused by coronavirus was SARS, which was caused by SARS-CoV. And so it was thought that it likely started out as a bat virus that then spread to this cute little animal called the palm civet, and then into humans through the wild game markets in China. And then the virus adapted and mutated to be able to readily transmit from human to human. So there was focal spread in different countries between 2002 and 2003. The virus was contained because, unlike this current COVID-19 virus, people were not infectious until they had already had symptoms for 48 hours. So once you found someone who had symptoms, you were able to isolate them and then halt the transmission. In this case, there were vaccines that were developed and tested against animal models, but because the virus then disappeared, it was never tested on, there were no human studies that were performed. So you all know about COVID-19. It's caused by the SARS-CoV-2 virus, and it's again thought to have originated as a bat virus that then jumped into another host and then spread into humans. But the details so far are unclear because there's some information circulating some information suggesting was circulating perhaps a little bit earlier than we thought. And so we likely won't know how this virus originated for several years. But I thought I would talk about the steps to vaccine development. So I really liked this little chart from the New York Times. And basically it shows the usual timeline for vaccine development. And then I'm going to show kind of how the timeline is being sped up for the development of the COVID-19 vaccine. So it can take up to 10 years for a vaccine to be approved for public use. And the process starts kind of at the top there with academic research and preclinical research before it ever gets to human studies. Now, it can take years to attain funding enough for academic research to occur, but what we're seeing now is there's a lot of existing research within the medical literature body about SARS-CoV-1, of which COVID-19 is very similar to, and another coronavirus that caused an outbreak in the Middle East called Middle East Respiratory Syndrome. And because of that research, they've allowed for shortening of the research and the preclinical time in order to proceed with human trials. Now, the next step in clinical trials, and I should outline that this is actually a process that occurs for not just vaccines, but really any sort of medical trial. So a diabetes drug, a drug for hypertension, a cancer therapy, all go through this exact same process. So the next step in clinical trials in general is divided into 3 phases, which you may have heard about: phase 1, phase 2, phase 3. And so I thought I'd talk a little bit about the phases, just to make sure that everyone understands. So clinical trials' main goal is to see if the vaccine works and if it's safe. And so people involved in clinical trials are all volunteers, and each phase of the trial is designed to answer certain questions. So in phase 1, it involves a lower number of healthy volunteers, and the purpose of this is to look for safety, as well as see some evidence of whether the vaccine appears to work. Now, because of the small numbers, that might not be visible until phase 2 trials. So in phase 2 trials, it involves a larger population, as well as targeting a specific population. So for example, if you want to see whether a vaccine prevents disease against children, you would include your children in these phase 2 trials. And then in phase 3, oh, sorry, I didn't advance the slide here. So we talked about phase 1 trials, phase 2 trials, and phase 3. So in phase 3 trials, the vaccine is then given to thousands of people. And again, you're looking to ensure that the vaccine is safe, and as well as seeing if it works because of the higher number of volunteers. So during all the trials, there's constant reporting of adverse events, anywhere from pain at the injection site to more severe adverse events like anaphylaxis. And even unrelated events are considered adverse events and reported. So for example, if I got the vaccine as a part of a trial and I went home and I got rear-ended by someone, I got into a car accident, that's actually reported to the clinical trial as an adverse event. Now, one way that this process, and so if at any point there's a concerning adverse event, the trial is halted. So you may have heard about one of the vaccines causing a suspected adverse event in the UK that resulted in the trial being halted, and then it's investigated and decided whether the trial is safe to proceed. And there is committees meeting at every point to make sure that the vaccine continues to be safe. Now, one way that this process has been sped up is during the search for a COVID vaccine, they've combined phase 1 and phase 2. So kind of right from the get-go, they've enrolled a higher population of volunteers. And therefore, you're looking for both safety, efficacy, and the right dose for the best immune response within that same phase of trial. And so the process of combining phase 1 and phase 2 trials is not new within the medical literature. It happens in many worldwide studies to minimize risk and to allow for faster development of an intervention. So you can see there, by combining the phases, you allow for shortening of that first portion of the development of a coronavirus vaccine. So if you can see there, from 2020 to, typically from 2020 to 2028, and now you kind of shortened it substantially. Now, another thing people need to understand is the speed at which a trial is done is very reliant on manpower. And so if you don't have money to be able to hire someone to enroll, let's say one person wants to enroll, a trial wants to enroll 100 people within the trial to meet their numbers, to be able to have adequate information to analyze. If you only have one person, it's very time dependent. They can't enroll 100 people in one day. Now, if with the funding that we have, they're able to hire 5 people, you can enroll a lot more people a lot faster. So, you know, manpower is very, and something that has been sped up with these trials. And so with all this funding, we're able to kind of cut all of these insufficiencies. So after the clinical phase, we then move on to the actual process of getting the vaccine physically available to the public. And you can see there, that's actually the bulk of the vaccine development process. So it actually requires building of factories, manufacturing, and then eventually distribution. And so a lot of philanthropic funding is allowing for building of these factories right now while the trials are still going on. So this is actually the bulk of what's being shortened within the vaccine development process. All right, so with reduction of all these insufficiencies, we've been able to cut down the timeline of vaccine development to a very optimistic 1.5 years. So by using research from SARS, combining the vaccine trials, building factories and early manufacturing of the vaccine right now, the process of vaccine delivery can be shortened substantially. Of course, all of this comes at the risk of whether the vaccine will actually be efficacious, but that's something that will remain to be seen with some of the literature. But the medical field in general has been provided with tremendous resources to try to optimize success. So in terms of studies that are close to finding a vaccine, there's several worldwide. Within Canada, there's 4 authorized trials. 2 of them are not novel coronavirus vaccines, meaning they're not new vaccines. They're vaccines that have existed that are being repurposed. So they're using it to see whether it has any effect in preventing coronavirus in certain populations. And then 2 trials are testing novel vaccines, but these are still in phase 1, phase 2. But there's several phase 3 studies going on worldwide. And as of September 14th, there was 5 vaccines in large-scale efficacy tests. So since we're coming up on flu season and the influenza vaccine will be shortly available, I wanted to talk very briefly about the influenza vaccine process. So throughout the influenza season, there is constant data and surveillance being done by committees into the strains of influenza virus that are circulating around the world. So in February of March, so actually in the midst of an influenza season, scientists are already choosing the influenza strain for the next year. And so vaccine strains are chosen 9 months before the actual flu season occurs. And if you remember what we talked about, antigenic drift, the influenza vaccine is constantly changing. So in that 9 months, it can change very slightly. And this is one of the thoughts of why you might actually have vaccine mismatch. So you may have heard, oh, the influenza vaccine this year wasn't very efficacious. This is the main reason why. So how fast did we get a vaccine during our last pandemic? Well, back in 2009, the first cases of the H1N1 pandemic strain was detected in the US, in the US and Canada in mid-April. And by end of April, they were already looking into investigation for a vaccine and started clinical trials by July of 2009, and the vaccine was approved by mid-October 2009. And that initiated, at that time, what was the largest influenza vaccination campaign in history, although this year might obviously overtop that. All right, so where can you get your influenza shot this year? So a lot of family physicians are doing these pop-up clinics. And speaking to my colleagues, they have like very innovative ways to make sure that everyone is safe. So a lot of people are doing it outside in a tent outside the office. So call your family doctor and see if they're offering the influenza vaccine. A lot of pharmacies are also offering the local influenza vaccine. And so if you go to immunizebc.ca, there's a list of pharmacies that are offering that. And then if you have a child 6 months to 4 years of age, you can call your public health family flu clinic. All right, so conclusions. So COVID-19 is a novel virus. There's a lot of things we don't know about it yet, and there's some things that we're still looking for answers to. But what we do know is that social distancing, washing your hands, and staying home when you're sick does prevent the spread of disease. And just a reminder, influenza does remain a deadly virus, and so vaccinating yourself can help protect not only yourself, but also the vulnerable people around you. And just to show you that the principles that are being preached have not changed in 100 years, this is an advisement from 1918, Illustrated Current News, about how to prevent influenza. So I don't know if everyone can read it, but I'll read out a few points. So it says, avoid those that cough and sneeze, don't visit poorly ventilated places, cover your mouth when you cough and sneeze, wear a mask, stay home if you have a cold, and avoid fear, worry, and fatigue. So thank you for attending my session today, and thank you for your attention.
Okay, we'll open the floor up for questions. Anyone have questions for Dr. Henni?
They haven't listed for this influenza season coming up what one they're going to be using, which is unusual with this close to that. Are they still working on it?
In terms of which vaccine they're going to be using, or which strains?
Vaccine they're going to use for this upcoming influenza season?
Yeah. So they have announced the strains that are included within the influenza vaccine. So we have 3 strains that are being included in the routine vaccination. And then there's a quadrivalent vaccine. What that means is there's 4 strains within that vaccine, and there's certain people that qualify for that vaccine. But this year we don't have the nasal, the flu mist, the nasal strain.
How many people died in the 2009 influenza, and in what countries?
Yeah, so it was a worldwide pandemic. Now, I don't recall the exact numbers of how many people died within Canada, but I do remember, I think in the United States, it was about 65,000, I think. So it was quite a severe pandemic, and mostly like a lot of young people. Yeah.
So my question is, if someone doesn't normally get an influenza shot, and then hopefully they built up some immunity, would this be a year that they should reconsider that due to COVID?
Yeah, I mean, I think, like I said, no one develops immunity to influenza because of the fact that the virus changes year to year. Now, there's some people who are very susceptible to severe disease, and those are people who are elderly, immunocompromised, although, some years we have seen that it affects people who are younger. So every year it is recommended to get your influenza shot because of the fact that the virus does change, and so it provides a little bit of a different strain.
So may I ask a second question along those lines? So then is it true that no one can build up an immunity to COVID?
So that's not known yet. So the question of whether you can be reinfected after you've had coronavirus is not yet known. We don't know.
I don't know if this is relevant or not, but have any of the zoologists studied the immune system of bats? Since they live so close and these viruses seem to thrive?
I'm sure they have. I just don't know the answer to.
Hello, one of my friends who's a frail 85-plus-year-old wants to know if home care can do her vaccine.
Sorry, I don't know the answer to that. I don't think that they do. The process of actually delivering the influenza vaccine is quite an intensive process. So, doses have to be ordered and delivered. And so it's something that is planned months in advance. And I haven't heard that home health is participating in delivery. But I don't know that exact question. So it's probably a good idea to ask her home health nurse.
Thank you.
I'm not against vaccinations. They've been very, very beneficial in history, but have you heard that people are 3 times more likely to get the COVID-19 if they've had regular flu shots?
I haven't heard that.
You haven't heard that?
I haven't heard that, but yeah.
Has anyone else heard that? No.
I just had a follow-up to one of the questions. Presumably, will we need to take the corona vaccine yearly, or that's still unknown?
Everything is still unknown about coronavirus at this point. So.
And how effective do you think the vaccine could be? Because in a given year, the flu vaccine oscillates between 30 to 40%, I believe, or 30 to 60%.
Yeah. So the 30%.
What would we hope for with COVID vaccine? Yeah. And my second, and part of my second question is, in clinical trials, what are the endpoints that you look for when you develop a vaccine? Is it in the humans? Are you looking for amelioration of the virus to be gone in the bloodstream, or are you looking for a clinical endpoint like reduction in symptoms?
Okay, So for your first question, so things are still unknown about coronavirus. Like it's not known whether you need to get it yearly, whether the actual specifics about the COVID vaccine are still not yet known. In terms of the question about what are the endpoints, so right now the trials are focusing on, does the body seem to mount an immune response against coronavirus with the vaccine? So once they give the vaccine to people, they check to see whether their antibodies mount a response. Now, whether that translates to actually preventing disease is what the purpose of phase 3 trials are for, and so that's still ongoing. Looking for that, still ongoing. So far, early trials have shown that when someone is vaccinated and they test their blood against antibodies, they do have antibodies against coronavirus. But whether that actually having antibodies actually means I'm not able to get the disease, or if I get the disease, it's less severe, is not known.
Just one more aspect to that I'm curious about. Is corona an animal that tends to have a lot of drift or shift like influenza, or is it, what type of virus is it?
So there have been shown to have mutations, but whether those are large enough mutations to develop into a completely new coronavirus strain is different. Like obviously, coronavirus itself is a huge family, and so there's various different types of coronavirus. So SARS, MERS, so clearly coronavirus itself can change, but whether SARS-CoV-2 can have the drifts and shifts is not known yet.
It does die quickly, though. It dies on surfaces quite quickly, is that correct?
So yes, what they're thinking is, there's always this debate of whether it's airborne versus droplets, but it's most likely droplets, and then there's different timelines that they have looked at to see, question, what do you need to wash your food immediately after you buy it because of the fear of coronavirus, and there doesn't look like there's been transmission from, household groceries or anything.
Is there a point where we would achieve herd immunity?
So that's a good question. I don't think that's known either.
Repeat the question, please. I didn't hear it.
Yeah, is there a point at which we will achieve herd immunity? If you look at influenza virus, that doesn't occur, right? Herd immunity doesn't occur. So, but you compare it to some of the other viruses, and there has been herd immunity, and that's why we vaccinate the healthy, and then people who can't get vaccinated are protected. We'll have to see. There are some countries who have taken that approach, but you won't know until things start to span out over several years. So.
I have one more question. If you could rank the restrictions or the recommendations, how would you rank them? So social distancing would be 1, wearing masks would be 2, and washing your hands more often with or without hand sanitizer would be 3. How would you, if you could only implement, how would you rank them?
Yeah.
As in terms of importance for reduction in transmission?
Yeah. Well, I mean, if you had coronavirus and I never saw you, I can't get coronavirus. So social distancing is obviously probably the key aspect, right? Like once you get into contact with people, then you expose yourself. But if you're over there getting coronavirus and I'm like, I'm not going near George at all.
That's true. Okay. Well, what about the other 2?
So, at that point, it really depends on the situation that you're in, right? Like if you are like face up against someone, but I'm not touching you, but I'm talking your face, then the mask would be the most protective. But really, like mask and hand washing go together. There's nothing that can work within isolation. Everything has to work together. All right. Okay.
So there was a case of a Hong Kong man contracting COVID twice, once early on in the epidemic, and then later on from a second source. Was that indicative of the virus drifting, or is that something else?
So the thought was there was a little bit of mutation in that, but it's still not exactly clear whether they were persistently positive or whether they actually contracted it twice. So there's still a lot of studies looking into that.
Well, they said that the two versions that they tested, when you tested positive first time and second, were very different. So how could it be considered
Yeah.
positive?
Yeah. So I don't know that that person was significantly symptomatic. So
No, he wasn't.
yeah. So that's the only real case that I've seen that has definitive what we call metagenomics, where they actually analyze the specific virus. But we don't know, like, why hasn't that occurred on a larger scale? So there's still, the thought is that might be potentially an indication that you can get coronavirus twice, but still not know.
Okay, we'll take two more questions.
It's not a question, but the last screen thing that you had, how to prevent the virus. Can you put that up again so I can take a screenshot?
Are you able to put that up again?
In the late 1500s, the bubonic plague went through Europe, and they practiced social distancing for, I believe it was 29 years before it died out.
The bubonic plague is airborne, meaning it sits in the air. So even though, like, you could come into the room and leave the room, and if I come in, then I can acquire it that way, whereas coronavirus is not airborne.
Okay, they still practice social distancing though in that plague. In the late 1500s, they understood that.
Yes, that's true.
When questions are asked on either end of the room, could you repeat so we can both ends can hear what's being asked, please? Thank you. You listen to that.
Thank you, Dr. Henni. That was great. Really appreciate it. Does anyone know what ENT stands for? That's the next topic. Ear, nose, throat. Okay, good. Otherwise known as otolaryngology. Anyhow, we're privileged to have Dr. Hartl, who's one of our ENT surgeons, with us today. He's been here for 6 years at ARH, and he has a focus in or special interest in endoscopic sinus and ear surgery. He treats both adult and pediatric patients. He's an instructor, clinical instructor with UBC, and is president of the BC Otolaryngology Society. He'll be talking about ENT in the broad sense. So welcome, Trevor. Happy to have you. Good. So this is your.
Wonderful.
And you.
I don't think so. Oh, that's nice. Sure. You won't see it. I won't. Okay. Will I see anything?
You'll see the slides.
I look this way?
Yeah.
Okay. Sure.
Yeah.
Can I take this off?
Yeah.
We're social distance, right? Well, welcome everybody. I guess fantastic that there's this big of a turnout on a Saturday that's rainy, and I guess it's a testament to your interest and commitment to our community and to the hospital. I'm one of the surgeons who benefit from the foundation and from your generosity. Can't hear? I'm really tall.
Yeah, that's tall. People got to go up here.
Can you hear me now? All right. I was just saying thank you. I'm one of the surgeons who benefit from your generosity and who I sort of appreciate your commitment to the community. I'm committed to this community. I'm actually an Abbotsford resident from way back. I was born at MSA. I did my training. Yeah, there you go. I did my training all over the place and then came back home, as George said, about 6 years ago, and I've set up my practice just down the street, corner of, well, it used to be Marshall, way further down Marshall, but this year we moved just in time for the pandemic to hit and for me to pay new bills, but we're just down, just off the McCallum interchange. I'm happy to be here. George asked me to speak on this several months ago, and as surgeons typically do, we just forget about all of our commitments until about the week before. So I've been working real hard on this for the past week to try to communicate some decent stuff to you. I said to him, so what do I speak on? What would these folks want to hear? And he said, I don't know. Talk about ENT, but try to make it interesting. Coming from a urologist, try to make it interesting. I think it's interesting. It's my life's work, but I'll talk a little bit. Here's the outline. think. Here. There. Yes. Talk about what it is that I do and my colleague Dr. Sai does in general in ENT, and then specifically what we do at Abbotsford Hospital. I thought since COVID-19 is the topic of the day that we'd speak a little bit about how the pandemic has changed our practice both clinically and operatively. And then I'll talk about what I think I've learned for my practice post-pandemic. So ENT is sort of, as George suggested, a relatively poorly understood topic, but it's actually a fairly broad and quite deep kind of surgical specialty. And in fact, unlike a lot of specialties, we don't have surgical specialties. We don't have a medical counterpart. So there isn't, you know, for George, for example, he's got urology, has nephrology. There's the medical counterpart. General surgery has gastroenterology, and it kind of goes down the line. We take care of both the medical and the surgical bits as it relates to the ear, nose, and throat. And here are just a number of pathologies that we treat. In the ear, hearing loss and dizziness, ear infection and deformity, injury and tumors. In the nose, we talk about the sinuses and breathing through the nose, allergy, deformity again, polyposis, epistaxis, which is nosebleeds, infections, losing your sense of smell, not related to the pandemic, tumors, and in our community, there's actually a big issue with cocaine. There has been for a long time, from Langley all the way to Hope. It's an issue, and the consequences in the nose is something that I deal with too. Laryngology is the treatment of voice and swallowing disorders, and we also treat tumors of the larynx. Head and neck surgery, we talk about the rest of the head and neck as effectively cancers, thyroid disease, and salivary gland disease. And pediatric ENT is where a lot of folks understand we belong. A lot of folks have children or grandchildren who have issues with their tonsils and their adenoids, so they're breathing at nighttime and recurrent infections. We do a lot of placement of ear tubes for fluid in the middle ear and chronic ear infections. You might have heard of that sort of thing. And we deal with a lot of congenital deformities. So all these pictures are pictures of my patients. Every photo that will be in this presentation, the exception of I think one of Bonnie Henry, are my patients. We're a team-based practice. So this is my private office. On the left, those are two of my team members. I also have an audiologist. And just like all surgeons, we have the private office stuff, and we have the working in the hospital stuff. Those are members of my ENT surgical team on the right there, Joanne and Greg. And this is Yasmin and Annalie. So we are a very technology-focused surgical discipline, as you might expect. So a lot of little holes require a lot of little instruments and a lot of lasers and microscopes and that sort of thing. An example here is lasers and microscopes. In these photos, you'll see me, I guess in the top left there, this entire photo segment here. It's me doing a laser excision of a left-sided vocal cord cyst. This was in a local lawyer's voice. So a fellow who used to be a trial lawyer had a real difficult time with hoarseness. We identified that he had a cyst, and we removed the cyst. And all of the instruments and tools and technologies that are employed to treat this kind of pathology as precisely and with as positive outcomes as we expect. We expect 100% voice outcomes in all voice surgeries. I mean, this is about $400,000 worth of equipment. Here is, I wish I could see these things and not turn my back to some of you, sorry. This is me on the left doing some endoscopic ear surgery, so replacement of an eardrum and a middle ear bone on a fellow who took a trauma to the ear, all done through the canal now that we have endoscopic ear instruments. It used to be the case that we had to make incisions behind the ear and lift the ear off and do all the surgery behind the ear through big exposures with drilling bone, and now we can do it directly through the canal, much less pain and very quick recovery. It's a lovely surgery, lots of fun for guys like me. And on the right there is endoscopic sinus surgery, and this is me doing a case that's with a PAPR, these spacesuits. That was in March when COVID was starting, and endoscopic sinus surgery was particularly dangerous, or at least we thought so. Still is, but we've learned a little bit more about the pandemic since. But this is a patient who had a tumor of the skull base, and access through the nose is the way we get to it. And that setup there, another sort of $500,000 setup on the right. This is this is an example of some of our pediatric specialty instruments and technology. So this is a thing that happens about 10 times a year in our hospital. We're a regional hospital, so we get some of the transfers of patients from, again, Hope to Langley. About 10 times a year, we have a child with an airway foreign body. This is a 3-year-old who swallowed a quarter. And the instruments that we have in the second slide there, I mean, we have a rigid endoscope that passes through a rigid bronchoscope, pediatric bronchoscope. And of course, we need different sizes for all of these instruments because we don't know the size of the child who might show up. It could be a newborn, it could be a 12-year-old, and all these instruments have to be the right size for the right kid. So we have these big sets. And then we have these, the third photo there is looking down the camera that is attached to an optical forceps. So it's a forceps that goes into the bronchoscope, that goes through the endoscope, and is, shown with these high-definition cameras on high-definition monitors for all to see. And because we have all of that equipment, we get to save 10 kids' lives a year. And these are some of the most rewarding and exciting cases I get to see. All kids do better. These are great cases. This is the most expensive stuff we do. This is the endoscopic sinus and skull-base surgery, and this is what Dr. Raybeck was saying is one of my interests. It's one of some of the subspecialty training that I've taken. What you see there is the entire operative setup. I'm looking at a 55-inch screen there. The nurse is looking at her own screen because she needs to see what I'm doing. Of course, this is down a hole in a nose. No one else in the room can see what I'm seeing unless they're seeing their own video of it. And of course, she needs to anticipate all the moves that I'm going to make and hand me the right instruments in time. And so she needs her own setup. We are using, in fact, the most exciting bit of all of this is to the left of that 55 screen, this bit here. That little screen is representing what we call image guidance. So anybody who has sinus surgery here at Abbotsford, and this wasn't true until about 5 years ago, but it is now, you have a CT scan that is taken preoperatively. And when you come to the operating room, your head and shoulders lie on this emitter of an electromagnetic field. And when my instruments that are connected to this CT scan that you've taken recently come into that magnetic field and into your head, I can see the tips of my instruments, which is important, right? I need to know, as you can see on that 55-inch screen, there's a lot of red, right? Anatomy is difficult to discern, especially microanatomy, even with the best visualization. I need to know just behind this wall, is there your carotid artery or your optic nerve? We're operating right next to your eyes and at the base of your skull. And so small bits of error have massive consequences. Now that we have this image guidance system, we don't have any eye injuries, skull base injuries, brain injuries. Outcomes are fantastic, and I can be more comprehensive in my surgery. I can take the whole tumor. I can get right up to the brain, whereas before we'd say, well, I don't know how far this is away. I'm going to err on the side of caution. So this whole system here is really fantastic, and again, lots and lots and lots of money. And sometimes we do knife and fork surgery too. We love to make fun of our colleagues who use knives and forks, scalpels and retractors and sutures and that sort of thing. Sometimes we have to do that too. This is an abscess. We all get bad colds and flus. Sometimes they turn into an abscess. Those abscesses need to be drained. These are things that used to kill people in the early 1900s, and they don't anymore. And that's a lovely little case. I think a 15-year-old with a branchial cleft cyst. It's really satisfying. Surgeons like us get to take what feels like an egg. I don't know if any of you have watched Dr. Pimple Popper, but these are my Dr. Pimple Popper moments. Taking big lumps out is weirdly satisfying to some of us. Again, like George said, pediatrics to geriatrics, from infants to the classic tonsil stuff to there's a person end of life with a big tumor, and we've had to put an airway in because she can no longer breathe. She was in fact an extremist, and we got the airway in, and she survived to live to at least attempt to treat the cancer. I thought it'd be interesting. I hope I'm not covering too much ground that others already have. We haven't had the benefit of watching other presentations, so I hope I'm not being too repetitive. But as I was putting this together, I found this very interesting, and I was able to kind of retrospectively walk through where my feelings were early on, and you might too as we go through this. But you may recall, and I got some of this from the government websites, that the first case in BC was in January. Now, I didn't think much of this at the time. I'll talk about there's a second bit here where the overlay is what I experienced as a person, individual from the system, and then as a surgeon, what we had to go through. A little inside baseball, I think that's fun. January 30th was the public health emergency. March 2nd was the toilet paper shortage of 2020. There was the March 6th sanitizer shortage. I remember paying $50 for Purell. You remember that? It was a big deal to get a big jug of Purell for my office. I paid $50, where prior it was $12 or something. Then we had our first outbreak in North Vancouver at the Lynn Valley Care Center, and then we had our first death at the same center. That photo is what made things really real for me. So Bonnie Henry is a personal hero of mine. I think if I ever meet her, I'll cry and give her a hug. I mean, I think she's been incredible for our province. But she broke down. I don't know if you remember watching this. Do people remember that one time she broke down in March? And I thought, if our public health leader is breaking down, this is real. This is a big deal. And that's when I got pretty scared. We had our first death. Then we had finally the World Health Organization called it a pandemic. And at that time, we only had 46 cases known in our province. We quickly said no gatherings over 250 people. Seems silly at this time. I remember when Whistler closed because we had a pass that we lost all of our money on. We were disappointed in that. And then I remember the borders to Canada were closed. There was that big dental conference, and all dentists decided not to operate. That was mid-March, not to work. The second half of March was where everything seemed to happen. In those 2 weeks, it went from this is a really kind of interesting, kind of scary, abstract thing to, geez, we might be in the apocalypse. Like, I remember that feeling distinctly. Bars and clubs were closed on March 17th. We were told to keep 6 feet apart, gatherings from 250 down to 50. Schools are not to reopen after spring break. My wife's a teacher. That was big news in our house. There was 183 cases in BC at that time. Then there was a state of emergency declared in our province, and all these other things closed. Late March was all of the provincial and federal financial support that was announced. It wasn't yet available, but it was announced, and so people could breathe a little sigh of relief. I thought, in fact, and this might be not popular opinion, I thought our provincial and federal government did amazing jobs to kind of keep us on track and not panicking. March 29th, there was this critical shortage of PPE for healthcare workers that was announced. I remember when it was in the news, it was in my office. It was exactly, there was parity. You know, I couldn't find masks for my staff and myself exactly when they were saying it was true on TV, or it felt like that anyways. So this is a little overlay of what was going on in my life at the time. I said, oh, there's a WHO pandemic emergency. I'm a terribly conservative investor, and I said, oh, I'm just going to sell all of my instruments. I don't take any risks, and I, later thought that I was very smart. Now you'll recognize that I was not that smart. There was a week in mid-March where Monday I came to work and we weren't wearing masks or gloves. And second, on Tuesday, I was wearing a mask and gloves. Wednesday, I was wearing an N95 mask. I was wearing this outfit, N95, a shield, a gown, gloves, keeping distance. Thursday, we closed the office. It was just like that. 4 days, we went from normal practice to it's over. There was hospital staff at Lions Gate that were infected. And then in my discipline, there was 2 pieces of news that spread like wildfire and really affected my discipline. And as Dr. Breivik said, I'm the president of our society for BC. And there's about 100 ENTs in BC who are looking for some guidance from our section leadership. And I suddenly got really busy doing things that had nothing to do with taking care of patients. It was all to do with that sort of stuff. But there was 2 things. There was a story coming out of Wuhan, China, that there was a single endoscopic sinus case like the one I showed you there, where all 14 people involved, from preoperative anesthesia to the operative staff to the post-anesthetic recovery and nursing, every single person was reported to have gotten infected. And 5 of them were reported to have died. Turns out, we learned 2 months later, that was a report of a phone call. This was terrible for our discipline. And the consequences I'll talk about in a second, but that was all nonsense. There was 14 people in that hospital that got sick. None of them died, and only 4 of them were tangentially interacting with that one patient, and there were outbreaks throughout the hospital. But that was one thing that got all of our backs up. And then there was a report that 5 ENTs had passed away in 1 week in these different places. And the thinking was, well, we deal with the airway, the upper airway. We're doing endoscopy as a routine assessment in our clinics. We're doing only surgery in the head and neck where all of this viral load is. We must be at super high risk. Maybe we should just stop working altogether. And then you think about the consequences of that. Well, I see 5 new cancers a week in my office. 5 new cancers. I didn't see patients for 2 months in my clinic, partly because they didn't show up, partly because they didn't see their doctors. Partly because our office was closed to all but urgent things. I would triage as appropriate, but that just didn't happen. So our anxieties were on both sides of the clinical dilemma, which is how do we keep ourselves and our staff and our families safe? How do we still meet our commitments to the community to care for them? Because disease doesn't stop. People don't stop getting cancers or all the other pathologies we described there. We held emergency meetings. We created guidelines that were terribly conservative at first. Where did I put it in here? Somewhere I put it in here. 7 ENTs came off of our call schedule. We have 7 ENTs across the province said, this is too dangerous. I'm just not going to see patients anymore. And 4 of them retired, and they're still retired. To go through some of the other things that was going on in my mind and what we physically went through in the last 2 weeks of March, my wife did a huge Costco run, and we still have a lot of all those dry goods in our pantry. My office closed to all but emergencies, like we spoke about. Elective surgeries were canceled. May 19th was when we had that phase 2 reopening, and we started doing elective surgeries again, but an entire 2 months of non-operation on anything that wasn't, death. I got my firearms license over a weekend. My dad was really worried, and so was a brother-in-law of mine. And we said, well, maybe we should go get a gun. I never got a gun, but we did go far enough to go get the firearms license training, and it was a fun thing for the 3 of us to do. But that's where my head was at. Who knows where this is going to go? It's kind of scary. Zoom became suddenly a big thing in the medical meetings world. Of course, it became big everywhere. So everybody knows about Zoom, right? This conference meeting kind of platform. I had no idea what Zoom was until mid-March. The Dow reached its bottom towards the end of March, and I thought I was a genius. I had missed this. I thought that I didn't know it was the bottom. I thought it was still going down. I'm sure everybody was in that same feeling. I deferred all of my loans and mortgages because my income was down for that 3 months about 90%. People thought that all this, doctors are doing great because there's all this. Well, we had to get all these deferrals too. And then the market started its biggest rally since the 1930s, and I still have not bought anything. So I missed out on, the greatest gain ever. Since then, Elective surgeries have restarted. Offices have been slow to reopen. With all of the guidelines that we have implemented, it has been exceedingly costly to be a doctor. We bear all of the costs. These offices are all funded by our own bank accounts, right? So when we need more people and we have to buy all this PPE, it's not free. And we have to take much longer to see patients and reduce our waiting rooms and all that sort of thing. It became quite costly. June 1st was back to school, whatever that means. Most kids did not go back to school. The good news is I spent a lot of time with my family on holidays through actually what was a really lovely summer. I didn't enjoy it as much as I think I might otherwise have, given all the anxiety, but there was a lesson learned there that I'll talk about. We had wonderful protocols that were implemented by really dedicated OR professionals. Our nursing teams, our unsung heroes were the people who cleaned in our offices and in our hospital. They were at a really high risk and they worked really hard. And then they implemented all of these at their own time and at their own expense, implemented all of these protocols for us to keep us, the surgeons and the patients, safe. And not enough credit goes to them. By mid-July, we were actually working at pre-COVID volumes, which was pretty impressive. Again, a testament to all of the work that went on with those OR teams. It was way more work. It still is way more work to get a slate done. But we're at least getting the same volumes as we were pre-pandemic. Government initiated a restart plan. There's a bunch of ways this is being implemented variably with variable success across the province, and I can't speak to all of it, but individually, surgeons have been offered time at these otherwise private centers for those of us who have really long wait lists. My wait list for elective surgery, it's between 18 months and 2 years. So to get space and time at other places is really nice, and the government bought these contracts. Offices are working at 80% volumes. Kids have been back at school, and all of us are anxious about what this means for our practices and for our patients. We're getting anxious, sort of like we were back in March again. I'm going to skip through a bunch of stuff because I'm running a little bit late. There was a lovely presentation provided to those of us who are section heads about how we start to create our own office-based protocols to ensure safety for our staff and for our patients. And we went through a lot of this. Not a lot of it's going to be that interesting to everybody here. Waiting rooms had to change, how we scheduled patients, how we greeted patients, our PPE specific to each procedure had to change. We do a lot of procedures in our clinics. Skip through some of this stuff, lots of nosebleed changes, tracheostomy, which is a big part of what we do. Hearing assessments were on hold for a real long time. I don't know if anybody here tried to get a hearing assessment or reassessment in that time period, but it was challenging. Trying to say goodbye to patients quickly was a difficult thing to do. There was a real strong association between the amount of time you spend with someone in close quarters, whether you're wearing a mask or not, and the infection risk. And we were told, try to limit your assessments to 5 or 10 minutes. It's really hard to do when someone's been waiting 8 months to see you and they have 3 things they want to talk about. And so we implemented things like phone calls before, follow-ups afterwards. But to be totally honest, it was impossible in my practice not to still sit with patients as long as they needed to be seen. We had to deal with our instruments differently. We had to implement new medical device reprocessing things. This is what I wanted to finish with. Another thing I got into was mountain biking with my son. That was lots of fun. We bought a couple of bikes before the big bike shortage of 2020. And we spent a lot of time biking together. Here are my lessons. I'm going to keep using masks and gloves. I don't know how I didn't use masks dealing with patients, doing these up close things before. I was always at risk for a cold or the flu or other things. I should have, and sharing those with patients. I'm going to do that going forward. Higher office sterilization and cleaning standards have been developed, implemented at much less cost than we thought it would be. Why not keep that up? It's a good idea. Telehealth will have a permanent role in my practice with follow-up with patients, doing investigations, triaging patients, rather than having someone come in to talk about their CT scan. Now I'm taking less time of theirs and of mine to call them up and say, here's what the CT showed. I'll show you the CT scan. It's great. We have been through a bit of this war philosophy is talked about a lot inside with doctors. We've been through something now. This is a generational thing that will have reverberations for camaraderie and how we work together. And that's a positive thing. I'm closer with my OVAR team than I've ever been. We've shared things and worked through scary things in a way that makes our relationship a little stronger and more special. And I'm happy about that. Taking a good history, I didn't realize how much I relied on facial expressions and the physical exam and the non-verbal things until I had to make phone calls and take a history. And at least I was able to, when I was taking histories over the phone exclusively, at least I learned how to do that better. And that's something a lot of us will continue with. I'm going to leave all my investment decisions to people who know about that stuff from now on. And I'm going to spend a lot more time with my kids. I think, my feedback to the government as they've initiated these restart programs, and another little bit of inside baseball, there's a suggestion that all surgeons should now work late. You should work till 8 o'clock, and you should work on the weekends. And that's a strategy. We weren't consulted on that, by the way. That's a strategy. The challenge is not only has this been emotionally and from your personal time point of view been very challenging and been a lot more work for a lot less pay, which is never what this is about, but it always plays a role. A lot of us got off the treadmill at 11. We were just going too hard. It's a common thing in surgery for us to be type A's and work too hard and too long. And a lot of us stepped off a little bit because we had to. We had to close our offices. We had elective surgeries closed. And we realized what else is available to us, our family, doing things that are fun. We had our evenings back. And so a lot of us don't want to step on the treadmill back at 11. We want to get back on it at 7 or an 8, because life isn't just about work. We've been forced to realize for the first time in decades, some of us. And so my feedback back to the government is, I hope you've got another plan. Because a lot of us, we're still contractors, we get to work as much or as little as we want. A lot of us are not going to be keen to be working more evenings and weekends to deal with these wait lists. We need to hire more people. We need to expand resources and not keep leaning on the folks. And let's not forget about the nurses who don't have the choice not to work on Monday because they work on Saturday. They've got to work all the time. Anyways, that's what I have. Thanks for listening to me. I encourage your questions. This is our trip to Tofino this year. Sorry my back was to you guys the whole time.
We'll open up for questions, please.
Do you recommend or do you take any vitamins, minerals, supplements for respiratory health?
The question is, do I take any vitamins or supplements for respiratory health? And I don't. No, I don't. I wouldn't purport to be an expert on that, though. What I often tell patients is that I'm a plumber. I'm a simple plumber of the head and neck. I know about your anatomy and your physiology, and I rely on the experts who are not surgeons to talk about things like that. So while I don't, I'm not suggesting that you don't. I just don't have an opinion.
As far as PPE and preparedness, whose responsibility is that? Is it local, provincial, federal?
As far as
what's being done for next time?
Yeah, so the question is, whose responsibility is PPE and how are we going to manage this for next time? That's a great question. And it's something we've wrestled with and I don't know the answer to. I think it is if we understand, as we should in Canada, that healthcare is a right. Healthcare is provided by our government, our self-government. We decided on that many decades ago with Tommy Douglas. It can't be the responsibility of an individual to find their own protection. It can't be the responsibility of a single physician to coordinate their own protection. It should be provided by the government. Which government? I don't know. The way that healthcare is administered in our country is provincially. You know, we have a single payer for each province, and then within our province, it's regionally. So the Fraser Health Authority right now has assumed responsibility for providing physicians and their offices and hospitals and their operating rooms, in my case, PPE. I think that's great, but I don't know if it's sustainable. We will soon see. But I think we're in a way better position now than we were back in March when this was a bigger problem. A lot of the supply chain issues have been sorted. You know, we've been forced to realize that you have to prepare for things like this. So, and the money's there, and the political will is there. Anybody else? Yeah, shoot.
Dr. Hartl, that stereotactic image guidance surgery that you do, is that available across Fraser Health? How did you obtain that technology, and is that a standard of care now?
That's a great question. So it is not available throughout the Fraser Health Authority. There are 3 hospitals who have it, and the question about whether it's standard of care is an evolving one, as it commonly is with technology and surgeries. So, you know, you hesitate to say that a colleague who doesn't have the most advanced stuff isn't doing good by their patients. You must rely on their outcomes and patient experiences to make that judgment. But moving forward, it will be very difficult to do very specific kinds of cases. Polyp cases, revision cases, tumor cases, basically those big 3, or patients with terribly complicated comorbidities without using this technology. It's generally frowned upon to take a big complicated tumor case to the OR without image guidance. It happens, but rarely, and that's an evolving situation. I'm sure you have similar issues in urology, right?
And how did you get it?
Well, how did I get it? Yeah, that was a lot of work. That was me lobbying before I was even hired. It's a condition of my employment shall be you must at least attempt to start this process. The process took a few years, and we got it. We had to apply through, you know, because there wasn't a contract for this system. Sorry, I'm talking too much. Because there wasn't a contract for the system across the health authority, we had to come up with the contract. We had to do all of the, what's it called? Yeah, there was we had to do all the base, the legwork to get a contract. And then after we did all the work, Burnaby got it first. The RFP, we had to go through the RFP process, and then Burnaby got it first. After we did all the work, I was so upset. But I'm happy for Burnaby.
One other question, dentistry. Can you comment on the because it's a similar space.
Yeah.
Comment on how the COVID has impacted dentists. Is there something where they should be doing, or?
We have a very tough relationship with dentists. It's a very one of these, you know, dentists operate in a private setting. They do things similar to us. We get anxious and angry when someone is charged $500 to get a biopsy because someone scared them. The dentist has scared them and says, "There's a lesion on your tongue. You should go down to the guy down the hallway and $500 for the assessment, $1,500 for the procedure. It's covered by MSP. Paid 25 bucks. We get anxious about that. So we've got a fraught relationship with dentists. They do more aerosolizing procedures. So they had to close because even a routine assessment was performed with aerosolization, all these drills and suctions, and we don't do any of that stuff in the clinic. So it was a little different in that way. I think the dentistry in BC was actually really responsible in the way they kind of closed things down pretty hard, and to their own benefit. I think they're reaping those benefits now. Yes?
So would you do something like acoustic neuroma surgery?
I don't do acoustic neuroma surgery. That's a good question. So I'm a generalist with some subspecialty interest, but acoustic neuromas, stapiotomy, cochlear implant, major head neck reconstruction where we take skin and bones from other places in your body and reconstruct things, those require subspecialty centers. So all acoustic neuromas are done at one center at St. Paul's Hospital. And that's, so for rare and complicated things, we generally in all of medicine like to centralize them. If it's that rare, it doesn't make sense for Dr. Hartl to do one every 2 years. It makes more sense for one guy to do 50 a year, because then they'll do, or gal, it actually is a gal, do 50 a year. So no acoustic neuromas in Abbotsford. Yes.
You mentioned that's where your head was at when you got a firearm. Could you go into a little more detail?
Well, I wouldn't say that I was totally rational about it. Part of it had to do with emoting with my family and connecting with my dad, who has a cabin in the woods as well, and he wanted to be, defend his space, and there's all that sort of stuff going on. I don't, I don't know if I was ever that concerned that I would have to defend my own property, but I'm a big fan of those zombie apocalypse type movies. And I couldn't help but put myself in the position of one of the survivors and go, it's either me or it's you, and I'm, you're not taking my, I don't know. I suddenly felt a little bit like a Texan, but I've come to my senses. I don't think that's, well, it's definitely not necessary. Not for that reason, anyways.
Great, thank you.
Cheers.
Thank you.
Okay, our last speaker before our lunchtime break is just outside. It's Dr. Gosal, Manjit Gosal, good friend and a family practitioner in Abbotsford. He graduated from the University of Manchester in England in 1992 and has been in full-time family practice. In Abbotsford for many years. He's also, and this is going to form part of his speech, he's obtained a master's degree in metabolic and nutritional medicine, and also practices in the area of functional medicine, which is kind of a newer area in primary care, family practice. On a side note, he's also a 5th degree black belt in karate. So we'll welcome Dr. Gosal. Good morning. This is your forward and back.
Forward and back. Right. And the slides, do I see them here anywhere or just on that?
No.
Oh.
And then there, sure. So you got to turn your head towards it.
All right.
Yeah.
Maybe I'll do that.
Turn this
Can
down.
I click from over here and it'll still kick in? Yeah. Okay. All right. Good stuff. All right. Good morning. I'm Dr. Gosal. You heard that I'm a family physician out here in Abbotsford. I need a microphone? Okay. Oh, I see.
Is there a mobile mic? No. Well,
Oh, gosh.
If you want to.
Okay, let's stand around here. Okay. Good morning. All right. So I practice family practice out here. I've been out in Abbotsford for, I don't know, close to 30 years or so. And I'm going to have a quick chat about stress. It's quite apt at this time. My karate background isn't going to help me much here. Though in karate, I'm subjected to a lot of stress in competition. I'm one of these crazy guys that used to compete in the open weight category. So I fight against guys who are 100 pounds heavier than me. I just thought it was kind of funny and risky, but I enjoyed it. And it's difficult for me to be here because I'm under stress, because I haven't done this for 25 years, right? So I haven't built up the stress resilience, the repetition of being in the same environment in order to handle what's happening out here. So my pulse rate right now is a bit up. It's probably around 80, 90, whereas usually it's around in the 50s. I'm sure my pulse, I'm a bit sweaty, my blood pressure is a bit up, and I feel like my speech is going to freeze a little bit too. But stress is really apparent right now, especially in the healthcare world with COVID. We've all had to change our lives, and as human beings, we like routine. We like doing the same stuff every day. We're used to it. Every now and again, we drive maybe in a different direction to work for a bit of excitement. But that's about it. So we know that stress has been increasing. We know that with the advent of technology, our stress rates went straight up. Smartphones, we're constantly looking at them, and all this tech has actually made life a lot worse than having phones at home where you just have to dial. Sorry, you just have to dial that thing. I still know how to do that. And then people have a hard time getting a hold of you, so you don't get stressed, which is, wish we were back there. We know that with this increased technical world and social media, we know that the suicide rates in adolescents has increased. That's huge, really important. So let me see if I can get this thing to work. As I said, I've always been keen on prevention. Stress is very close to my heart. Everybody's under stress. I had a major episode of stress about 20 years ago, and that's where I was a young physician, working multiple clinics, doing OR assists, and teaching karate 5 times a week, preparing myself for the nationals, which meant training twice a day. And also I was doing obstetrics, yes. So all of that, so all this night work, all this physical stuff, all this mental strain. And one day I woke up and I was in pain. I was like, oh man, my body's really hurting, more so than my usual exercise. And so I rested for a few days, and then I tried to train, but I'd feel more miserable. And in fact, though I could usually manage an hour and a half of exercise, I found that 10 minutes would put me down, put me out for 3 or 4 days. So my colleague said, oh, you're miserable, you need to be on antidepressants, here's an SSRI. Right? But I thought, yeah, I'm not that kind of miserable. I'm miserable because I can't exercise. Right? I can't keep up. So I've always been interested in inflammation. And so I went into research with regards to inflammation and found that my physical and mental stress caused all these free radicals to occur in my body. And that inflammatory oxidative stress messed with my neurochemicals in my brain. And so I started treating myself with antioxidants and resting. And I saw at that time an anti-aging physician that we messed around with a few hormones. And in about 8 weeks, I was about 80% better. And then after that, I carried on studying inflammation and went through and did the master's degree and became a functional medicine doctor. So that's me. So, oh, went wrong way. Where stress has many different faces. This is one of them. This is another look for stress, and that's pretty much where I'm at right now. Kind of timid. So we're going to go through looking at stress and cortisol responses, the normal cortisol response, or the diurnal rhythm of cortisol, a bit about a normal fight or flight response, and what happens when you're under undue, prolonged stress, and we'll touch on a bit about prevention of this burnout. So this chap, Dr. Hans Selye, very important chap who did a lot of research into stress, essentially coined the term stress. He was a Hungarian-Canadian endocrinologist who researched out of McGill University. So from him, we came up with this thing. So our performance stress curve. Now, if you don't have any stress, just like if you don't have any inflammation, you're not really doing much. You're kind of lackadaisical. When we start pushing ourselves through the day and we get tasks to do and we have deadlines, we become more efficient. We start multitasking and we're more efficient. And we want to be in this kind of optimal range where you have your adrenal gland kicking in, which produces all these hormones to help you with stress, or to cause you some stress. So in this range, we're flowing, right? We're efficient, multitasking. Athletes would be, they're saying it that they're in the zone, right? They're in the zone, everything excellent. Now, you push a few more buttons and you get more stress, miss some deadlines, and your boss is picking on you. And then you start going over the edge, and that's where you start crashing a little bit. You start missing things, your memory lapses, you get some anxiety, some insomnia, and if you keep on burning the candle at both ends, then you burn out, and then you're stuck. Okay? So obviously, we want to try and do something about this over here, right, before you get into that situation. So adrenal gland, the two key hormones that play a part in stress are cortisol and epinephrine. So when you're under a bit of stress, cortisol rises, and on the coattails of cortisol, epinephrine goes up. Cortisol and epinephrine help break down some of your stores of protein, protein, fats, sugars that give you glucose that goes into this metabolic cycle, Krebs cycle, and then you get glucose, and then through the electron transport chain, you get bundles of energy, quite literally, these things called ATP that get you going. So here, this is normal life. Mr. Caveman, unfortunately, there's no corner store where he can go in the morning and get himself some groceries. So he's got to go out in the morning and go hunting and gathering, right? So as the sun goes up, cortisol goes up. These are actually saliva measurements of cortisol. Saliva. Because it's much more stable than serum levels, right? So serum levels of cortisol, you could be going to the lab and you hit a red light and you get a bit frustrated and your cortisol spikes up in serum. But saliva is what the research is done on, and saliva is what NASA astronauts, those guys undergo these tests to see if they're fit to go up in space. F1 race car drivers have this kind of a test because their team wants to know, are they optimal? Can they handle that endurance race, which is, they go at 200 miles an hour around really sharp corners. They got to be on for a long time. So anyways, in the morning, cortisol goes up. By the afternoon, he's happy, he's got some food, goes back to his cave, and cortisol eases off again. This is what should normally happen. Both of these guys are under stress. One guy's trying to survive. The zebra is trying to survive, right? He's getting chomped up by the lion. And the lion's trying to survive too, right? Because he's got to push himself. He's really hungry. If he doesn't eat, he's going to die. So both are under that acute stress. And as I mentioned, both of them push on cortisol and adrenaline. When that happens, a few funky things happen. So we know that we get glucose for energy. A couple of interesting things happen during that fight, in that we have a part of the brain called the hippocampus. That's a memory center, right? Hippocampus. And what happens is we shrink the hippocampus a little bit. Just atrophies a tad amount, right? Why? I don't know, but that's what happens. Maybe it messes with your memory. Seems to happen to some people who are under stress. Another thing that happens is there's part of the brain called the amygdala. The amygdala is your emotion center. So that shrinks a little bit when you have super high cortisol too. And that's to do with emotions, emotional disturbances. So some really interesting things happen when these hormones are spiking. So this is when you're pushing a little bit too hard. Right? When you're pushing a little bit too hard, this is the first thing that, on average, this is the first thing that happens is you start pushing cortisol a little bit higher, and you drink a bit more coffee, keep yourself going, and you push harder, and then you feel the heat a little bit, right? Now, if this goes on for days, weeks, months, the cortisol level drops off. So cortisol from the adrenal gland is controlled by the brain, hypothalamus, and at some point the hypothalamus decides, hey, cortisol is way too high. This is not good. When cortisol is too high, parts of the immune system, one part of the immune system kind of shuts down, and maybe the brain recognizes that and says, oh, let's slow this down a bit. So the brain stops communicating with the adrenal gland so efficiently, and so cortisol starts to dive. And then we get into that, oh man, I can't get up out of bed type of a situation. If that pushes on for months and months, super high stress, well, you find this, and there's a researcher, Dr. Elizabeth Blackburn, who's done a lot of research into cortisol and stress, etc., and found that when you have a flatline cortisol response, cortisol dysregulation to this extreme, you get these types of problems. In some cases, you get chronic fatigue syndrome, fibromyalgia, PTSD, autoimmune diseases, cancer crops up. And if you've already got the cancer and you flatline your cortisol, there's poor cancer survival as well. So, very important, chronic depression. This is where I have a quick sip of water, if I brought it, excuse me. It's better. Great. So, as a functional medicine doctor, I like looking at the body as a whole. I like understanding how one system affects another system, because our physiology is immensely complex, and we're actually very resilient there. So we can handle a lot of problems. We can get cough, colds, flus, we can get injuries, and we still survive and carry on, right, with all these infections and stresses. And it takes a perfect storm to really wreak havoc on us and give us a disease, be it cancer or cardiovascular disease or diabetes. It's not just a singular thing. And we talk about, genetics. The genetics is a little bit to play into even stress. Stress resilience or tolerance is also determined by a little bit of genetics, but a lot about environmental factors, what you endured through life, right? So anyways, I like looking at systems as a whole, and this is a common system that I see in patients when I'm treating patients. A lot of people come in with fatigue, stress, have this connection between the adrenal gland, the thyroid, and the pancreas. And one can think of it as, oh, already got it. Let's put that over there. So this can be provoked at any side and affect things in different ways. But the most common thing is your person is under a bit of stress. So they're under a bit of stress, the adrenal gland is kicking in. And what happens next is that cortisol goes up, of course, cortisol starts spiking, and then it starts doing some funky things to the thyroid. So adrenal, thyroid, sugar, pancreas. You can think of it as stress, metabolism, and sugar in its most simple, really simple basic terms, right? So when you have cortisol spiking high, you actually start dropping your thyroid function. That happens with a few different types of mechanisms, but in particular, T4 is not converted very well into T3. And T4 also gets converted into a thing called reverse T3, which plugs up T3 receptors. So you get a slowdown in your thyroid function. One of the reasons why that happens is because we mess around with this enzyme called deiodinase. Sometimes with stress, you can get micronutrient deficiencies. That enzyme slows down its function, and you can run into problems there. And what happens after you decrease T3 is you get insulin sensitivity or insulin resistance. So I'm sure you've all heard about insulin resistance, when you're having to push your pancreas to make more insulin in order to control the blood sugar, right? right? So your pancreas works a little bit harder at trying to shuttle glucose into the cells, right? And that can be thought of as like a pre-diabetic state. And with this combination, for example, slow down metabolism, you get obesity, high cortisol and adrenaline, you get some hypertension, you get into a pre-diabetic state. I talked a little bit about this. This is all the stuff that happens when you have cortisol dysregulation, right? Lots of other things happen, altered immune system, inflammation because of these little messengers, chemical messengers. DHEA, a really important hormone, which does help you keep immune, keep lean, but also is related to immunity. So, nutrition deficiencies, serotonin for your brain, very important to keep you happy. Start dropping that, and unfortunately, get pudgy, right? Really bad. So, insulin resistance can cause all of this stuff and much more. obesity, atherosclerosis, renal disease, dementia, cancer, lots of bad stuff happens from that. So what do we do about this, right? I've kind of rushed through it, but what are we going to do in order to stay healthy? We have to maintain that cortisol rhythm that I showed you, that normal one where it's just spiking in the afternoon and coming down. You want to maintain that as much as possible. I think the most important thing is getting your Z's, getting your sleep, immensely important. As I said earlier, you tend to burn the candle at both ends. Then you cause a lot of hormonal disarray. Your neurochemicals start messing around and you get miserable. You need to have 8 to 10 hours of sleep. In order to correct all of this, you need to get into a deep sleep. You have to have cycling sleep where you get into stage 3 REM sleeps and you're producing things like alpha waves, which are a bit like meditative state, alpha waves. There is a supplement that I like, just on a side note. It's called L-theanine. I really like it. Super cool. I like talking about L-theanine all the day, every day. L-theanine is used in Japan. It's a part of green tea. It's an extract of green tea, and it works on your neurotransmitters, serotonin, dopamine, multiple ones, and it is extremely safe. Actually, extremely safe. In Japan, they give little kids like 3-4 grams of this stuff for ADD, ADHD to chill them out and get them focused. You know, I've given 200 milligrams twice a day, and I take it because I'm like, if I didn't take it today, I'd be a bit messed up. It wouldn't focus very well. L-theanine also helps memory function. Anyway, so alpha wave is very important. Meditation, studies have shown meditation for sure. 10 minutes of meditation twice a day helps you get back that diurnal rhythm of cortisol. Simple, cheap, don't have to pay anything. Tai Chi, Qigong, yoga, all similar things. Breathing exercises, we forget how to breathe. We forget how to breathe. A lot of us, when we're under stress, we start breathing with our chest, using these muscles up there, instead of using our diaphragm, abdominal breathing or belly breathing. So when you're breathing with your abdomen, your diaphragm pulls down, and you actually get more air going into your lungs. Simple, right? But whenever you're under stress, you have to do a self-check. Your shoulder's a bit tight. That's what I do. Shoulder's a bit tight, neck's a bit tight. I must be stressed, right? And so I start belly breathing. I have this little thing called red light meditation. So whenever I hit a red light when I'm going to work, rather than getting annoyed, I chill out and do some belly breathing. Very simple. Good studies on stroking pets. Calms down your cortisol response. Exercise. Appropriate exercise. Right? So if you think back, when I was pooped out, totally exhausted, I exercised, I felt even worse. Horrible. And that's what doctors say, you're feeling miserable, go out, get some more exercise, push harder, push through it, right? And I don't think that's such a good thing every time. It depends. I mean, I've been fortunate enough that I've checked cortisol responses for numerous patients. Is what I found is when they have those little bounces in cortisol during, say, the afternoon, that's when I'll say, you know what, you seem a bit more energetic then. Why don't you exercise during that phase? then you won't get trash. Let's just give you a little bit of exercise there. What I've done with them, with a few of them, is if they've had the time, they're not at work, etc. If they've had a bit of a rise of cortisol in the evening, I'll give them exercise at that point. And as I steadily increase the exercise, I've actually pulled them back so that they're not exercising at 5 anymore. They'll pull them back to 4, then 3, then 2, then, to try and get them exercising in the morning. And that, I don't know, it seems to work. They start feeling a lot better because that's what the normal cortisol response is. That's what they're telling me. It sounds kind of cool. I haven't done any major research, but seems neat. So another thing is in Japan, forest bathing. Forest bathing, fantastic. Doesn't actually mean that you go into the forest and have a bath of water and all that stuff. What it means is you're awakening all 5 of your senses and getting in touch with nature. Nature walk. Lots of studies from Japan show that reduced blood pressure, reduced cortisol, reduced diabetes, decreased or improved survival rates in cancer. And they have found this little chemical called phytoncides produced by these plants which we're inhaling, which maybe help, right? In fact, they started prescribing, it's called social prescribing in England now. So you're going out in nature to treat yourself. And with that, what they found was you had a 28% reduction in GP visits, reduction in referrals to specialists. Right? So getting in touch with nature is obviously very important, and we're missing that right now in a big way. And it's a simple way of treating ourselves. So social prescribing, and of course we've talked over the last few years about exercise is medicine. Kind of sounds like integrative medicine. Right? And not many people like the term integrative medicine, but I think we're heading in that direction right now. That concludes my talk. I hope you found that a little bit interesting, and I managed to get through it, and I didn't crash, I didn't fall, I managed to keep talking. Everything's good.
We can take some questions now,
Yeah.
please.
Any questions?
And can you speak into the mic so the audience at home can hear?
Oh, at home. Oh, gosh. All right. Oh, geez. All right. More stress. Yes.
Can you please spell that vitamin you were talking about?
Simple L hyphen the THE ANINE. That's a little pearl. The other pearl I should give you is that how do you know when you're getting distressed, right? I like doing this. I like checking my pulse rate once a week, or knowing through my Fitbit what my baseline pulse rate is on a weekly basis, and I look for a trend. Right? Simple test, right? So I wake up in the morning. I haven't even got out of bed, so I'm totally resting. Check your pulse rate, and then mark it and see what's happening over the next few months. If your pulse rate is starting to come up, then what's happening is either you're getting super unfit or you're getting more stress, because pulse rate is related to the sympathetic nervous system. That's your accelerator, right, in your car, right, your gas pedal. So sympathetic nervous system is kicking in too much, pulse rate is increasing. And we've got to learn then to put the brakes on the parasympathetic nervous system to balance the autonomic nervous system, those two things, right, very important. So that's a simple test to see if you're getting heading towards burnout. And of course, see if you're cardiovascularly fit as well. Yeah?
Practice in the Abbotsford area, or where do you practice?
I practice in the Abbotsford area, yes. But I mostly do general practice. Yeah. Because I'm not quite sure where we're at in terms of what our climate is right now in terms of practicing.
Have you studied the COVID-19 at all? like can look at nutrients and things like that, which might build the immune system?
All of those things are assumptions. There are no large studies on them. I have my own little regimen that I do.
What would that be?
This is my regimen. I can't advocate it. I can't say it'll help you, but there are a few things that I take. I take vitamin D3, of course. Vitamin D3, I take vitamin C. I take reishi mushroom. I do get my hands on a little bit of a DHEA. I do take curcuminoids. And I think that's enough. At one point, years back, I was on about 42 different supplements. I went a bit crazy. There's too much good stuff about it. That was a bad move. That's a very bad move.
Is there a particular green tea that has this?
Gyokuro. It's called Gyokuro. Gukoro. Gyokuro green tea. That has the highest.
What about zinc?
Zinc? Oh yeah, that's true. Yeah, I take some zinc. Problem with zinc is you take it beyond 3-6 months, you start getting copper depletions. So then you got to add in a bit of copper. All right.
I have one question. Oh,
yeah.
Go ahead.
Are all mushroom extracts the same?
Simple answer is no, and it's a bit beyond my scope. I haven't looked at all of those.
Some are better for the immune system than
Some are better for the immune system, some are better for maybe cancers. But again, these are not big studies. There are a lot of petri dish studies on them, right? So.
But you eat a sensible, reasonable diet as well.
Oh, 100%. Back to the basics. Good nutrients, fresh nutrients, lots of vegetables, colored plates, not pre-made, colorful plates. I mean, yeah, and not, 5 plates. Keep it simple. Right? So, yeah.
Dr. Gosal, is there something we can be doing as a community to facilitate this functional medicine and make it more accessible to everybody, whether it's parks or?
More accessible, yeah. Doing talks, learning about integrative care is useful. Education is the mainstay, but you can go into the supplement world and looking all of those things. That's not where it's at. Where it's at in terms of prevention is what you're doing on a daily basis with your life, right? We only have X number of seconds in our lives. It's the most valuable commodity, time, right? And we have to think about how we're going to spend that time. If you're always, again, burning the candle at both ends, busy, you're wasting that time. And I've learned that you actually have to shut down what you're doing in order to make your life valuable. So that's the best thing to do. You got to integrate exercise. You got to integrate good diet. I like intermittent fasting. So, those are the kinds of things.
Yeah. Great, thank you.
All right, thank you.
Thanks, everyone. We're going to take a break now for about 30 minutes. There's food and snacks available. We can't have everyone going at once, so maybe these two first rows of tables can go, and then we'll go every 5 minutes. We'll reconvene. We'll start the next talks at 11:45.
and make eye contact with everybody, but I was just saying I should have worn my heels so I could have seen a bit better, but I apologize if I don't quite get to see everybody, and I guess I need to stick close to the mic here. I also just want to add, I was born and raised in Abbotsford. I was born in the old hospital, and grew up on a farm, graduated from Abbey Senior, so I know a lot about this place. My family's still here, so I'm pretty happy to have started my career here, and I'm hoping to finish it. So I've been here now for 18 years. So yeah, I'm going to talk about our breast health clinic today, which hopefully my mic is okay, which we started, we'll go to the next slide. We started in 2011. We spent a couple of years or more having meetings and talking about how we were going to set it up. And basically the main goal with setting it up was to try to speed up and streamline the process of patients that were diagnosed, that would be diagnosed with breast cancer. I had been here, well, since 2002, so being the only female surgeon here for many years, female general surgeon, I was seeing a lot of female patients and a lot of breast patients in my office. And I would certainly see, you know, by the time they got to me, it sometimes was 2 or 3 months from when they maybe felt a lump or had an abnormal screening mammogram. And certainly the stress that they were feeling as they were waiting for tests, waiting for biopsies, was very difficult for them. And even for patients that ultimately ended up not having cancer, you know, they would spend several months stressed out waiting for these tests just to find out they didn't have cancer. And I think it's important for those patients too to try to get through the process a little bit faster. So, so as much as we're mainly about diagnosing breast cancer, next slide, certainly most of the patients that we see don't necessarily have cancer. So just briefly about our clinic and how it works. When we first started, we were just in the back hallway of the cancer agency with 2 phones and just a few rooms. And now we have a lovely clinic on the first floor here in the hospital. It's a very small clinic. We've got a couple clerks, a couple nurses. Our clerks spend a lot of time on the phone, and they're often actually the first point of contact for some of our patients. So, you know, someone who's found out they have an abnormal mammogram, they're going to be quite stressed. And I think our clerks do a great job of sort of talking them through the next step, which is often coming into our clinic. We have 2 nurses. One is our surgical nurse that does a lot of the patient assessments. She deals with some of our post-operative patients, and both her and our program coordinator, who is also a nurse, have taken on a big counseling role over the years, which has taken a lot of really weight off of my shoulders. Obviously, being diagnosed with cancer is stressful and traumatic, and perhaps the most significant thing someone's had to ever go through. And our nurses have, they do a fantastic job at, you know, initially discussing things with the patient and giving them a bit of an overview of what the breast cancer journey can look like. So often by the time the surgeons have seen the patients, they've sort of got a pretty good overall view of what they might be looking at. One thing that was incredibly important for me when we were first making up the clinic was how was it going to run physician-wise. There we see most of the patients we see, which you'll see soon, do not have cancer. And as a surgeon, I didn't necessarily want to be seeing every single patient. So very early on, we found a core group of family physicians. They are all female. They wouldn't have to be, but they are. And right now we have a group of 4 or 5 physicians. They all spend probably 1 day a week in the clinic. They see a lot of the patients initially, do a little bit of counseling about breast disease, mostly benign breast disease, non-cancer disease, and they do the basic breast exams as well. And then I'm one of 2 surgeons that works in the clinic. Dr. Terry Leung is the other one, and we both, over the years, our practices have really progressed to being almost all breast disease. So we're not the only 2 female surgeons in town now, but that's basically what we do. So next slide, please. As you can see, we see about 3,000 patients a year in the breast clinic, and only 6% of those patients ultimately are diagnosed with cancer. So as I said, those family physicians that work in the clinic, they take a huge load off of our shoulders. If we had to see all of those 3,000 patients, that would be a bit of a burden. So you know, our clinic does a great job at dealing with, you know, other patients with other diagnoses, breast pain, cysts, benign breast lumps. We see patients with infections. You know, our median age, as it says, 55 to 60, but we do see a lot of younger women. We do see about 2% of our patients are male. Those are not necessarily breast cancer patients. Men can have benign breast tissue enlargement as well. We have had probably about 10 male breast cancer diagnoses since we started in 9 years. So it's certainly not very common to see male breast cancers, but we have seen it. And our cancer patients, certainly the majority of our patients would be sort of 50 to 60, but our youngest breast cancer patient was 25, and we've seen up to age 98. So obviously the management considerations are very different in those age groups, but we see anybody essentially. So next slide. There's basically 3 ways that patients can end up seeing us in the clinic. So most patients will come to us from their family physician or sometimes from the emergency room. And those are patients with a breast lump or possibly pain or an infection. So as you know, I said, we don't necessarily see just cancer patients. We also see all patients with abnormal screening mammograms. So if you have a screening mammogram and there's a change or an abnormality seen, your next contact will be one of our clerks from the breast clinic calling you. And that's where they have to have some empathy because they're obviously telling someone that they may or may not have something serious. Obviously, from our numbers, most of those patients aren't necessarily going to have cancer, but they often need more tests and they have to come in and get an exam. And again, very important when we were setting this clinic up, I really wanted to be able to have this self-referral option for patients. So many people nowadays do not have a family doctor. I am now one of them. But, you know, I really wanted patients to know that they could phone the clinic. Usually for those patients, we would immediately have them talk to one of our clinic nurses. You know, they'll ask them what their symptoms are, if they have a lump, if they've had a recent mammogram, and then they'll book them in, usually to see one of our clinic family physicians initially. And if they haven't had a mammogram, we would book that as well. So that's not necessarily very publicized that we do self-referrals, but we definitely will take patients. So if for any reason there's a delay for your family doctor to see you, or certainly in this day and age, if they will just talk to you on the phone and not necessarily do an exam, we will take patients into the clinic if you phone us and chat with our nurses. Next slide. So I just wanted to talk a little bit about more maybe the diagnosis of breast cancer and what we do in the clinic. So breast cancer diagnosis, we talk about this triple assessment. So imaging or x-rays are really important with breast disease. Obviously, if we are going to diagnose someone with breast cancer, we want to find it at a very early stage. We don't do the x-rays in the clinic, but we work really closely with our radiology colleagues, and we actually have spots just for us to book ultrasounds, mammograms for our patients. And, you know, sometimes we'll have patients who perhaps their family doctor has ordered an ultrasound for them. The tech will often contact us, the tech even that's doing the ultrasound, and say, this is really suspicious, like I think you guys should be involved. And so, you know, we'll have patients even end up with us that way, just to try to expedite things. Physical exam is very important for breast disease. We'll talk a bit more about that. And then biopsy. So obviously a lot of the patients we see don't have cancer, and taking a sample of an abnormal lump or tissue is really important to try to clarify what is going on. So we'll talk about what kind of biopsies we can do. Next slide. So x-rays, like I said, really important because we want to find any breast lumps or cancers when they're small. So mammogram, there's two types of mammograms. So most of us have had screening mammograms, and that's where you can phone in and book yourself. They do a couple quick pictures, and yes, it squeezes things and it can hurt, but it's quick. And then there's something called a diagnostic mammogram. So if you have an abnormal screening mammogram, often you'll have this diagnostic mammogram. That's something that would have to be ordered by a doctor, so your family doctor or us in the clinic. And basically with that, they're taking more pictures of the breast, and they can zero in on the area that's abnormal, do what are called magnification views. Also, once someone has had breast cancer, they will have diagnostic mammograms. They will never have screening mammograms anymore, so they will always have the more detailed mammograms afterwards. Not all breast cancers are seen on mammogram, and we know that. So at least 10% aren't seen on mammogram. And, you know, some cancers, just the nature of the disease, they're just not able to be picked up. Sometimes ultrasound will then be used. So if someone has a lump that we can feel, but their mammogram is normal, it's really important for those people to have an ultrasound because that will sometimes show things. But even if you have a lump that isn't visualized on any x-ray, you know, that's sometimes where us surgeons come in, where we end up having to make a bit of a clinical decision. Do we still need to biopsy this lump? We have had some patients who, rare, but it's not seen at all on x-ray. So sometimes we might be biopsying something or following someone closely, even if the x-rays aren't helpful. We do use MRI sometimes for breast disease, but we don't use it very commonly, certainly in the United States. Probably every person with a diagnosis of breast cancer will get an MRI, but it's a little different in Canada. Certainly it's overkill to have everyone get one. Most of the time it's not going to change your management, but there are some special circumstances where it will be used. Next slide, yep. So we call it a CBE, clinical breast examination is what the physical exam involves. Again, a lot of patients don't have family doctors. They will possibly never have had a breast exam. Some family doctors, male family doctors, may not be comfortable doing breast exams. They may not have someone that can chaperone them. You know, some clinics do have a female physician in them that does sort of the female type exams, but we do have patients that just have never had a breast exam. So we want all the patients who we have referred to us to come in for an exam. So that's usually by our clinic family physician. And again, with those breast cancers, you know, there are some that aren't seen on mammogram. So if we do feel a lump, you know, we still will, if it feels suspicious, we'll still go through and investigate it. The nice thing about our family physicians is they see a lot of breast patients working in the clinic, and they, I have to say, are very good at picking up suspicious lumps. They've picked up some they've got good fingers basically when they do their exams. So, you know, again, you know, we don't mind if a family doctor even sends someone in just for us to assess if they're not sure, because we have a lot more experience dealing with breast disease than they do. Next slide. So if we think that there's something suspicious with x-rays or physical exam, the next step would be a biopsy. So we have doing a biopsy is essentially you want to take some tissue, take a sample of whatever you think is suspicious. So we do this with a lot of things in medicine. With breast disease, we would do either what's called a needle biopsy or a surgical biopsy. Ideally, we do a needle biopsy, and that's something that I think I have a picture of, but we'll talk about this first. So they can use an ultrasound or mammogram to help show them the mass and then guide the biopsy needle into it. If it's a big lump, then sometimes we can do what's called a freehand biopsy. If I can feel it, I can just put some freezing in and do it without the ultrasound. That would be the ideal way to figure out what's going on. If it is a cancerous lump, we can plan more definitive surgery or treatment right there. However, it's not possible, there are sometimes some physical limitations for our x-ray doctors that do these biopsies. Or sometimes, especially if it's small, it can be quite difficult to actually get into the the lump. So if they aren't able to get a good biopsy that explains a lump, then sometimes we have to do a surgical biopsy. Next slide. So a needle biopsy, so this, sometimes if it's a small lump, our x-ray doctors do these biopsies and they use ultrasound or mammogram to help show them where the lump is. And basically, we're putting a needle in and taking a tissue sample. Ideally, we usually would do it 2 or 3 times, just in case you're not quite in the lump the first time. Ironically, yeah, if it's a really small lump, it can be quite difficult because the biopsy needle might be a couple millimeters, and if the lump's 3 or 4 millimeters, you're trying to hit something very small. So that's what a needle biopsy involves. Next slide. But if we can't do that, we have to do a surgical biopsy. The downside of doing a surgical biopsy is most of the time we would do it in the operating room. It is a general anesthetic. It's a bit more invasive as well. It takes surgery time, and we're usually taking out a bit more than just a small amount of tissue. If we do a surgical biopsy and it ends up being a cancerous lump, sometimes those patients then need a second surgery to perhaps deal with lymph nodes or something else. So we don't necessarily jump in to do this unless we have to. And we do it with a small lump that we can't feel. We do something called the wire localization. And this always, I think, sounds a little bit crazy. But what we do is the mammogram pictures on the bottom of the slide show a wire in the breast and then in an x-ray of the sample that's been removed surgically. So when we do this wire localization, these patients have an appointment in x-ray the morning of their surgery, and our x-ray doctors put this wire in, either with ultrasound or mammograms. So they literally put some freezing into the breast, and then they take a little metal wire with you can see, you can see on the second picture there, there's a little hook on the end. So they literally put a little wire into the breast with the hook right beside or into the lump. The wire sticks out of the skin. They put a big bandage over top of it. And then when you come up to the operating room, when you're asleep, we make a little incision and we go in and take out the wire and the tissue to take the sample. So sounds a bit weird that you're walking around with a wire sticking out of you, but it's only for a couple of hours. We always make sure that this gets done the same day. Next slide. So just briefly, I don't want to get into treatment too much, but if we get someone diagnosed with breast cancer, usually surgery is the first treatment, and that's something that we arrange through the breast clinic. As I said, there's 2 of us surgeons that work there, so we can arrange surgery and usually give patients a date when we see them. Most of the time, surgery is the first treatment for breast cancer. There are some times where we might do chemotherapy, which is drug treatment before surgery, and so that's a decision that we do make as surgeons. And we also work very closely with our colleagues at the BC Cancer Agency. It's really nice having them in the same building as us. There have been times where I just run up there to discuss a case with one of the oncologists and get an answer right away. It's we've also been able to start expediting our referrals to the cancer agency so that we sort of save probably at least a week or 2 for patients waiting for their next appointment to see the oncologist. So we're very happy with that, and our oncology colleagues are great at talking to us again if they have something that needs more surgery. So other treatments that can be used for breast cancer, and not everyone needs everything. So there's a very individualized approach for breast cancer. So chemotherapy, which is drug treatment, radiation, which is x-ray treatment. And then there's a type of hormone therapy we use. It's the opposite of what women go on at the time of menopause. It's like anti-estrogen treatment. Not all cancers can be treated with that, but if they can, it's nice. It's just a pill that you take for 5 years. doesn't have all the big bad side effects that chemotherapy would necessarily have. The other thing that we can do through the clinic is we now are able to offer breast reconstruction for patients who require mastectomies for breast cancer. We've been able to do this sort of off and on over the years, but we now have a plastic surgeon the last couple of years who's very interested in this. And we actually have a very busy breast reconstruction program now. One thing that patients have to realize is that it's not necessarily a one-stop shop where you go in, get your breast off and walk out with a nice perky breast. So it often means a couple surgeries to finish off the process, but we can do the first portion of the reconstruction at the time of the mastectomy, which is certainly for patients losing their breast. Nice to know that they're going to at least have something there, and then they might need another surgery or two, but usually any subsequent surgeries for the reconstruction are much easier than the first one. So we're pretty happy to be able to offer that to patients as well now. Next slide. So just to summarize, so I mean, our goal overall with the clinic was to improve and speed up the process for patients that are being diagnosed with breast cancer to get them into treatment sooner. I was actually a little surprised, but apparently 75% of our patients get that diagnosis within 3 weeks of presentation. Certainly sometimes, you know, with weights, you know, even though we have our own X-ray, ultrasound, mammogram spots, you know, sometimes we're still pulling strings, trying to find enough room to get everyone in. Our waits, for example, sometimes for ultrasound and biopsies can stretch into a few weeks. And that's difficult to rectify because there's just limits to the system. So I was somewhat happily surprised to find out that we still are able to get most of our patients through 75% within 3 weeks. And like I said, you know, I've always felt it's really important for those patients who don't have breast cancer, which obviously most of our patients that we see, those 3,000 people, only 200 of them have cancer. For those patients with benign breast disease, we're also hopefully getting them to a resolution of things faster as well. So there's a lot less anxiety and stress for them as they're waiting for tests and results. Any questions? Yes. Technically, you're not supposed to have a screening mammogram, but I'll use microphone. Sorry. So technically, yes, the mammographic, the sort of overall recommendation is that you're not supposed to have screening mammograms after 70. Your family physician could still refer you for a mammogram, and I don't think it's unreasonable to, you know, if you're healthy, to potentially still have mammograms up to 75 or so. Hopefully those recommendations will change now that people are living longer. But, you know, we do have to take an individualized approach. So, you know, a 75-year-old with, you know, significant cardiac issues may not be someone who's going to live to 90, and they can probably stop having mammograms, but certainly someone who's healthy, you know, we see lots of people into their 80s. You know, I saw this week an 89-year-old and a 96-year-old, both with breast cancer, and obviously our management considerations can change and it does become a bit more complicated. But yeah, you know, technically the recommendation is for screening mammogram only to age 70.
Yeah, actually had breast cancer.
Mm-hmm.
So it's always concerned now, 70.
Yeah.
I don't really mammogram that anymore. But it's nice to know that I can actually consist of.
Yeah, if you talk to your family doctor, I don't think it would be unreasonable. And if you do, if you, like I said, if you feel something or have any concerns, you can call the clinic and talk to one of the nurses. And yeah, we're happy to see you. Yeah, for sure. Yes. Not necessarily. So there are genes that predispose you to breast cancer. So one is the BRCA gene, which has been in the news. It's the Angelina Jolie gene, if anyone knows. Anyway, I actually saw a man this week who was found to be BRCA positive. He had a niece, I believe, who was diagnosed with ovarian cancer, and all ovarian cancer patients in British Columbia now get tested for genetics. He had, I think, one family member who'd had breast cancer, but even with the fact that he was BRCA positive, his risk of getting breast cancer really is only 1 to 2% over his lifetime, whereas for a female, just being female and having no other predisposing factors, our risk of getting breast cancer up to the age of 80 is about 10%. So even for the men who have that gene, that, for women, it can be that gene can be up to a 70% risk of getting breast cancer in their lifetime. So those are the patients that might have prophylactic mastectomies. That's a whole nother talk. But even for the men that have that gene, their risk of getting breast cancer is still much lower than the average woman. So breast cancer in men, definitely not very common, but it can happen. And the treatment is really about the same as it is with women. So, yeah. Oh, well, sorry. Is there another question? Oh. So that's a whole another thing. The recommendation is still like every 1 to 2 years. The breast density, that's a new thing over the last couple of years. The unfortunate thing with it is that if you have denser breasts, there's no hard and fast recommendations right now as to what to do. So having denser breasts does increase your risk of having breast cancer versus having less dense breasts. So that basically means that on mammogram, it's not just because it's harder to see cancers on mammogram. We know that just in general, patients with dense breasts have a higher risk of getting breast cancer. But unfortunately, there's nothing out there right now that says these patients should then have MRIs there's nothing, no good recommendations. So, basically what I would say is definitely have a mammogram every year, be very self-aware of your breasts. If your family doctor does do breast exams, try to get them to do one every year or so. Just try to be very proactive. Unfortunately, there's no good recommendations as to what to do if you have them. So we get now, if you have a screening mammogram, the radiologist will make a comment on how dense your breasts are. But again, that other than being very aware of that and being a little bit more proactive and breast aware, we don't have any special recommendations right now. Yeah.
Maybe one more question.
Oh. Yeah. Mm-hmm. Oh, good. Oh, good. Yeah. So even if you're not, you're over 70, just be proactive. Yeah. Yeah. And I think it's fine to continue to do mammograms because, if you've made it to 70, you might be making it to 95 or 100. And yeah. So, all right. Do we have one more?
And I haven't had a mammogram since I was 70, and I was sent to the breast, your clinic, and was told I had dense breasts, but no recommendation, like you said.
Yeah.
That I should continue to have mammograms. So.
Yeah, there's nothing sort of written, but I don't think it's unreasonable. You could phone the screening.
You just phone the screening?
I just phoned the screening.
Yeah.
Yeah, and I mean, if there is a concern, you know,
There really isn't a concern, and my doctor does do a
yeah.
breast exam every year with my, with my yearly exam. So, and he says I have dense breasts too, so, but I'm thinking maybe I should be.
Yeah, I don't think it's unreasonable if your health is good to continue to at least 80, and then maybe after that. But yeah, it's, yeah, and people living longer is becoming more difficult for us making decisions as well. So, yeah. All right, I think I'm getting kicked out. So thank you very much.
Thank you so much, Coreen, Dr. Dyck. Thank you. We see that with prostate cancer as well. When I trained, it's exactly the same thing. We were told don't do a PSA screen after the man is 70. Now we're living longer, and it's really more about life expectancy, but we don't have a crystal ball. So
They've stopped, they stopped doing cervical smears too.
yeah, so part of it is
At 70.
Part of it's payment and part of it's access. It's a lot easier to get a blood test for a PSA than to maybe do a mammogram, but yeah.
I can see more sense of the Pap test.
So our next speaker is Dr. Gaurav Bahl, who's a radiation oncologist at the Cancer Agency. So this kind of goes in line with what Dr. Dyck was speaking about, and he actually does prostate cancer treatment as well as some breast treatment. He's a professor of radiation oncology affiliated with the UBC hospital and the UBC medical department. And he's actually the president of our medical staff at ARH. And he actually he did specialty training at Princess Margaret Hospital, which is one of the foremost cancer hospitals in Canada, in Toronto. And he'll be speaking about radiation oncology and where the Cancer Agency fits in. So please, let's welcome Dr. Bahl. Getting this. So, thank you. So this is, you're on PowerPoint, right? So this is your advancing. You want it, and then you. Perfect. You can have a few minutes for questions. Sure.
Thank you, George, for the introduction, and thank you for having me here today. I'm one of the radiation oncologists at the Cancer Agency, and I'm just going to go through kind of an introduction to what radiation is all about and what we do here at the Cancer Agency in Abbotsford. Okay, there we go. So radiation therapy or radiotherapy is essentially the use of various forms of radiation to safely and effectively treat cancer and also some other benign diseases. Almost 70% of all patients with cancer will at some point in their journey need radiation therapy. Radiation therapy is the primary modality for radical treatment in almost 40% of patients with cancer. And radiation oncologists such as myself are physicians who are trained to prescribe this radiation therapy. Radiation therapy is not new. It's been around for over 100 years. 1896 was when they kind of discovered X-rays, and within a few months they were experimenting to treat cancer with it. Of course, it's come more into focus in the past few decades with the modern advancement of technology and, sorry about that. Computers and newer machines and linear accelerators allowing us to deliver more precise radiation therapy to higher doses and at the same time reducing side effects. So what is radiation? We all talk about radiation and X-rays. What is this? Radiation is energy. It's pure energy. The packets of photons, the energy from the Big Bang, from Einstein's equations, the God particle, if you may, they are pure energy. They're massless packets of energy that go through significant depths of space and tissue. And for us radiation oncologists who are Star Wars fans, yeah, we think it's the Force. So what is radiation? The types of radiation that we use, they're basically two types of radiations, commonly known as X-rays and gamma rays. X-rays are the ones that we produce using electricity. So we use a beam of high energy electrons, which is electricity, which is bang into a target of heavy metal like tungsten, and that produces X-rays. And they're the same X-rays that you use for a chest X-ray. The ones that we use to treat cancer are just very, very high energy X-rays and can deliver a lot more energy. The other type of radiation is gamma rays, and this is the radiation, radioactive radiation that we talk about. These are radioactive elements like radium and uranium that actually emit radiation. And these can be some naturally occurring elements and also ones that are specifically synthesized for treatment, such as iridium, cobalt. So how does radiation work? Well, radiation works by actually depositing energy within our cells, which are able to damage the DNA of cancer cells. So 80% of our body is water. When these high energy bundles of particles go through our body, they ionize the water molecules. And these then go and interact with the chemicals in the DNA inside the cells and destroy the strands of DNA, which results in tumor death. Now, the reason why it's more effective on tumors as compared to normal tissues is the reason why we also give radiation in small bundles every day over a prolonged period of time. Because every day the radiation causes little bits of damage more and more to the cancer cells, and eventually the damage results in shredding of the DNA and the cancer cell dies. DNA in our body is used when the cells actually try to divide and multiply. And in most people, our cells are not dividing that rapidly. It's the cancer cells that are dividing rapidly. Furthermore, normal tissues or normal cells have certain enzymes that can repair the damage that the radiation causes. So when the radiation goes through the tissue and causes the damage to the DNA, the body is able to repair that damage because the DNA is not of immediate use because that cell isn't actively dividing. It's also one of the reasons why radiation has more side effects in children and more side effects in tissues that are growing, like our skin and the lining of our mouths and the lining of our bowels. So when is radiation used? It's used for different situations. Oftentimes, the decisions are multidisciplinary with the radiation oncologist, the medical oncologist, as well as the surgeons. And they're used sometimes alone, sometimes in combination with surgery and chemotherapy. Radiation can be used to cure cancers, to essentially destroy the tumors, or also be used in situations after surgery to try and reduce the risk of the cancer coming back in high-risk situations when there may be a few tiny cancer cells left behind after Dr. Rayback's gone in and taken out the big chunk of it. They can also sometimes be used to shrink cancer before you go in for surgery, to just shrink it down, make it smaller so that Dr. Rayback can get at it without causing too much damage to the body. A lot of radiation is also given for palliative purposes. So to reduce symptoms, to shrink cancers when we feel they're not curable or they're metastatic, to help with pain and other symptoms and improve quality of life. Now, it's all teamwork. There are a bunch of specialists who actually result in the formation of a radiation plan and the delivery. Radiation oncologists, of course, the physicians, but there are also medical physicists who are much of the brains behind the radiation planning and all the technological advancements that we've had over the past few years. We have dosimetrists who actually work to create the plan. We have radiation therapists who actually run the machines and deliver the treatments as planned every day. There are nurses, and of course, several other members of the team, such as social workers and dietitians and nutritionists and dentists as kind of help with the treatment planning. So what can a patient expect in terms of the process? Everything starts with a referral, consultation, and then the treatment planning. The referral is often, I would say, the rate-limiting step because a bunch of information is needed before we can see someone for a consultation and make the decisions. The diagnosis, such as getting a biopsy or certain CT scans or images, and oftentimes this referral process can be challenging. A consultation is when the radiation oncologist actually sits down with you, goes through the evidence and the findings and diagnosis, as well as prognosis and what the treatment options are, including side effects. Once there is a decision for a treatment plan and a decision to go ahead with radiation, there is a lot of planning work to be done. And we essentially use three-dimensional imaging with CT scans, often nowadays integrated with MRI scans and PET CT scans, to actually delineate the tumor and identify sites to give radiation. Once we have this imaging in place, there is a process of treatment planning, which the oncologists and the physicists go through to develop an appropriate treatment plan. and then the actual delivery, where in the majority of cases, patients are coming into the hospital every day, checking in, waiting for their turn, and getting radiation, which is often about a half an hour to 45-minute appointment every day, Monday to Friday, ranging from 4 to 6 weeks, depending on the type of cancer that may be the situation. So how is radiation actually delivered? There are two ways of doing radiation, which can be broadly defined as external radiation or internal radiation, or what we also call brachytherapy. External radiation is the X-ray treatments. These are the high-energy X-rays delivered using linear accelerators, which are the modern machines that can produce these using electricity. And internal radiation or brachytherapy is when we actually insert a radioactive source right inside the tumor to provide radiation from within. And these are done in certain cancers like prostate cancers and cervix cancers, and I will give you some examples as we go through. So what are the types of external radiation? The most commonly used radiation nowadays is three-dimensional. So there's three-dimensional conformal radiation, where multiple different fields of radiation are delivered concentrically to the target. And the more modern form is intensity modulated radiation or volumetric radiation, where there's actually a computer program that goes through various iterations to come out with a best treatment plan to be as conformal to the target. For many, many years, I would say till the 1990s, the way we delivered radiation was two-dimensional, based on X-rays. And the radiation beams went in one way and came out the other way, and there weren't too many other options. So this is what would be a typical plan for someone with a head and neck cancer. You would take an X-ray and we'd kind of divide it into segments and just put some blocks to protect the eyes and reduce the dose of the spinal cord, and the radiation just goes through and through, and everything gets radiated, which is in the field. This was how treatment was delivered. These are blocks put right on the machine. These are pieces of lead to try and reduce the dose of certain structures. These are other cutouts of lead that were made to try and modulate the dose and try and protect structures in the area. But there wasn't too much that could be done to really change or have a differential sort of dose distribution. Then came along CT scans and modern three-dimensional imaging, which allowed us to really see the cancers very well, to draw out the target volumes and also draw out structures like the eyes, the brainstem, the spinal cords, and try and reduce the dose to these structures while increasing dose to the cancer itself. The way we do this with modulated radiation is using something called MLCs, or multi-leaf collimeters. So these are thick, almost 7-centimeter leaves of lead, and a computer program makes them go in and out as the animation on the side to try and modulate the beam of radiation in different directions as it comes out of the linear accelerator. And this allows for very conformal distribution of the dose. Now, this is an example of what treatment looked like in the older days, when there was one beam of radiation coming in from here and one coming in from here. Everything pretty much got the same dose of radiation. So if you wanted to spare the spinal cord and give it a lower dose, then the cancer here also got a lower dose. But this is what we can do with newer techniques, where we can actually draw out exactly what to treat and almost do what we call dose painting, or carve it out to protect the salivary glands, protect the spinal cord, protect other structures, and do amazing things to try at the same time to increase the dose of radiation to where the bigger bulk of the cancer is. The other technique that we have is something called stereotactic radiation. This is highly precise radiation where we actually fix a frame onto the patient so that the patient can't move, and have very, very high doses of radiation delivered often in very few fractions. So this is maybe one treatment or 3 to 4 treatment rather than the 4, 5, 6 weeks of treatment, but can be delivered to small targets like something inside the brain. This is a very high dose of radiation. It kills everything. So this is very conformal treatment for very specific indications where we want to really obliterate cancers. For example, if someone has a cancer with a single metastatic lesion, say in the brain, and no cancer anywhere else, we can now go after that single lesion and get rid of it. The other advancement that we have is something called image-guided radiation therapy. What image-guided radiation therapy does is we actually have a CT scan on top of the linear accelerator or the radiation machine. So every day when the patient comes in, the machine goes around and takes a CT scan. They reconstruct the image and then match it to the initial planning image and move the machine accordingly so that we can deliver treatment more accurately, because things inside the body move. For example, when we're treating prostate cancers, if you've got gas in the rectum, prostate goes up. If your bladder is full, the prostate goes down. By doing the CT scan, we can actually track after the prostate and treat less of the bladder and rectum, so less side effects. Rapid arc or volumetric treatment is when actually the radiation machine continuously is going around the patient in an arc. And while it's going around, the computer program is making these leaves of lead go in and out to block different structures as they turn around. So in this video, the patient's not turning, it's actually the machine, as you can see in the lower corner, that's going around. And as it approaches, say, the spinal cord, the leaves will come and block it out. And when it approaches the cancer, they move out and deliver those in. And this makes treatment delivery very fast. With this volumetric treatment, it's like 3 or 4 minutes to actually deliver a full dose of radiation. So this is just an example of what we can do with these modern technologies. So this was a 35-year-old patient with an atypical meningioma. So these are kind of not very aggressive, but they are brain tumors, which grow slowly and can cause a lot of problems by involving the structures. It's just the location of this tumor right in the center of the brain, wrapped around the optic chiasm and the optic visual nerves and the brainstem and all the critical structures. She had surgery. They basically were able to remove the protruding mass at the top, but this neurosurgeon couldn't go down into the main structures near the brainstem because that would cause devastating side effects. So what we did was the intensity modulated radiation for this patient. We were able to give the tumor dose while carving it out to protect the nerves going to the eyes. And you can see the way the dose goes in and out to protect that nerve in the center. And we're able to give it a high dose. And oops, let's go back. So this is what happens 6 months after radiation. It's smaller, but doesn't look too different. That's because radiation kills the cancer where it is. It's not surgery. It doesn't make the cells disappear. It's over time that the body itself eats away at those cells and slowly removes them. So this is what it looked like after 6 months. This is what it looked like after about 18 months. And this is what it looked like about 36 months. And the patient's doing well and has her vision and stuff intact. A little bit about the internal radiation or brachytherapy. This is when we actually use radioactive material placed directly into the tumor tissue. And these are small bits of different radioactive materials, which can be low dose or high dose. And an example is on the side, where these are the small seeds that we use for permanent implants into the prostate. The permanent implants are low dose radiation, so they release a little bit of radiation slowly over a period of time until they decay and are inert. The temporary implants are very highly active source, which we place inside the cancer for a while, usually a few minutes, and then take it out using what we call after-loading applicators. Brachytherapy is done in operating suite, mostly under general anesthesia. This is kind of an example of the operating room. And this is what we call our HDR machine. So this is, it's a safe, we call it a safe of thick lead. It houses a radioactive source, which is about half the size of a grain of rice. And that is enough to treat cancers. Just 1 to 2 minutes of exposure to that is enough for a dose of radiation. And you can imagine there's a lot of radiation safety required and procedures required to keep that safe and confined, otherwise it can be a major hazard. Cervix brachytherapy is a common example of brachytherapy for cervix cancers. We use these sort of applicators to place them inside the uterus in the operating room. We then connect them to the afterloader, and the radiation source is sent right inside to deliver those right to the cervix and uterus area. And this is very precise treatment because when it's inside the tumor, we don't need to worry so much about the normal organs because we're treating from within out rather than from outside in. So we can really pump up the dose to the tumor and reduce dose to the normal structures. Prostate brachy, as I mentioned, is another example. This is done under ultrasound guidance. We place a number of needles through the skin into the prostate. It's done in kind of using a template where we would identify the prostate gland, put needles right through the skin into the prostate and leave these small beads of radioactive iodine inside the prostate. This is kind of what a pre-plan looks like. We need to do a lot of pre-planning before we actually take the patient to the hospital, to the operating room. And this is a CT scan of an implant showing these little seeds that have been implanted in the prostate. We'll also do an MRI for them and fuse images to kind of get an idea of the plan and make sure that, you know, the dose to the rectum and other structures is appropriate. Another thing is what we call skin brachytherapy or surface mold brachytherapy. This is where we put the source very close to the cancer for skin cancers right on the surface. So we make custom designed molds or applicators for each patient depending on the size of the tumor. In British Columbia, this technique is only available at the Abbotsford Hospital, and we've been doing this for almost the past 10 years. We make these custom designed molds, and there are these small cables that you can see that are attached to the mold. These go connect to this afterloading machine. And then a little bit of iridium is at the top of a cable, which goes through the wire right to where this lesion on the nose is, delivers the radiation, goes back inside the safe, and then we take the mold out. We also have the new fancy 3D printers now, so we're able to print these molds rather than making them by hand, and that makes things faster and more easier for the patients as well. This is just an example of an elderly gentleman with skin cancer on the forehead. This would require, in terms of surgery, a graft and require general anesthesia for that procedure. So we decided to do the surface mold brachytherapy. This is a CT scan image of the mold that's placed on the skin. And this is where the radioactive source is housed and delivers radiation to a fairly high dose to the skin and tapering off to a minimal dose towards the brain tissue. And this is kind of an image after. Similar patient with a larger larger tumor on the scalp. This would require major plastic surgery to fill the defect if it had to be removed. We were able to make a mold and do a pretty good plan and had a good response after. Another patient with a lesion on the leg causing erosion right down in, which is a little deeper volume that we had to treat, and again results. And this is a very good alternative for surgery to people who want to avoid surgery or are not suitable to surgery because of age or general anesthesia, and as well as for cosmetic reasons, like because the cosmetic outcomes are good, especially on the face and ears and other structures. Radiation doesn't come without side effects. There are side effects to treatment, which can be mild to moderate to severe, depending on the type of the cancer, depending on the location of the cancer, and the dose of radiation that's required, depending on if surgery, chemotherapy, and other treatments are added on. Acute side effects are what we call side effects that happen during radiation or during the few weeks after radiation. And these are managed in the hospital while someone's having treatment and usually go away in a few weeks. A late toxicity or long-term toxicity happens because of damage from the radiation. When there is damage to the DNA of normal cells and the body, for whatever reason, is not able to repair that damage, there can be permanent issues depending on which part of the body is treated. And on an average, 5 to 10% of patients may have some long-term issues because of the radiation therapy. So I just want to emphasize that cancer treatment is teamwork, not just different specialties of physicians, but also our nurses, our physicists, our radiation therapists, dosimetrists, social workers, nutritionists, dietitians, and of course, family and friends who form a big support to our patients going through radiation therapy. So that was just a little sort of trailer into our lives and what we do down in the basements of the cancer center. And I'm happy to take any questions or concerns.
Any questions for Dr. Bahl? It's very impressive technology. Yes. Can you push us into the future? Is there some other equipment or treatments that you're looking to provide?
Well, they're always coming out with something new. I think we are still working getting the newer machines for stereotactic radiation. In fact, we've just had a new machine installed at the cancer agency a couple of months ago, and we'll be getting another new machine which are all capable of doing stereotactic radiation. So we hope to see more and more disease sites where we're able to do this and go after even metastatic cancers. So I think that's kind of the change that's happening.
So I guess it depends on the brain tumor itself as far as doing any like radiation therapy on that. Like,
can you repeat the question a little bit louder?
Yeah, no, I'm just thinking, you know, that brain tumor that, you know, did quite well with the radiation treatment. Other ones don't do as well. Is there certain types that do it?
Yeah, so there are all different types of brain tumors, right? So there are low-grade tumors to high-grade tumors, and all depends on, you know, the treatment modalities that are available for that specific kind of tumor. And there's also a differentiation between a primary brain tumor, which arises from the brain, versus a cancer elsewhere in the body that actually spreads to the brain and results in a metastatic lesion in the brain.
More of one that starts in the brain, an astrocytoma type?
Yeah, so the astrocytomas or glioblastomas are kind of the more high-grade tumors, and they require a combination of treatments with surgery followed by radiation as well as chemotherapy, so they are more intensive.
Switch over.
Okay, any other questions? Well, thank you very much.
Thank you.
Okay, our next speaker is Brian Lee from radiology or medical imaging. Dr. Lee is originally from Kitimat and spent last 20 years in Montreal doing his medical school and residency training, and decided to return back to BC and has been with us now for about 2 years. So welcome Dr. Lee, and he'll be speaking to us on medical imaging.
Hello. So I'm Brian. I'm one of the radiologists here. I just wanted to say thank you for having me out here to speak to you about medical imaging. My pleasure. As was briefly stated, I am one of the newer radiologists in the department. Originally from BC, I moved to Montreal when I was a bit younger. Lived there for about 20 years. I did all my training out east, so my med school, my residency, my undergrad was all at McGill. And after my residency training, I did an extra year of training in musculoskeletal imaging, so a lot of learning about bones, joints, muscles, other soft tissues. And when it was time to start practice, I decided to come back to BC with my family and call this area my home once again. So that's what's brought me out here, and have been here for the past 2 years, and certainly plan to stay here indefinitely. So I was told that this is kind of a, yeah. Sure.
Line balance.
Is that a bit better now? Better, okay. So I thought, based on some experience, whenever I mention to somebody that I'm a radiologist, I often get quite a few blank stares. Some people have some concept that it has something to do with x-rays, but beyond that, maybe the understanding of radiology is somewhat limited. So I thought I'd just take you on a bit of a brief tour through the medical imaging department to give you a feel of what we do on a daily basis as radiologists and technologists and everyone that works in the department. And as you can see here, I've said that medical imaging is just more than just x-rays. So there is much more to it now these days. All right, so who are we in the medical imaging department? Certainly we are a few radiologists. In our group, we have about 25 to 30, depending on the time of year. We have some people that come through on a temporary basis. But the radiologists are, in fact, a minority of the department. We also have a large contingent of technologists that help us, without whom we would not be able to do our job. They receive specialized training in how to operate all of the technology and the machines that we work with to help acquire all of the images that we get, whether that be X-rays, ultrasounds, MR, or any of the types of imaging that we use. And they're the ones that interact on a daily basis with the patients and have a certain understanding of the the underlying pathology of disease, to help bring all that information together for us, acquire the images, and present everything to us as radiologists so that we can interpret the images and hopefully come up with some sort of diagnosis and report. In addition to the radiologists and the technologists in the department, we have a large support staff, we have administration, we have our booking clerks that help everyone get into the department on time to have those appointments scheduled, people that keep everything in stock and keep the whole area clean too. So it's a very busy department on a daily basis. Radiologists are part of it, and like I said, we're kind of a minority, and without the whole team, we certainly wouldn't be able to operate properly. So what do we do? As radiologists and radiology, I find, is a little bit of an antiquated term. Certainly 30, 40 years ago, the only type of medical imaging that existed was x-rays, and I think that's where the term radiology comes from. But medical imaging is definitely much more appropriate these days. And if I had to summarize what we do as radiologists and everyone in the department, is that we use any type of medical imaging to come up with a diagnosis. So we have a bunch of tools at our disposal, which I'll go through in a few minutes. I'll show you some pictures to help primary care physicians answer questions and hopefully come up with some sort of diagnosis. So a typical workflow or pattern that we would have is that a patient presents to their primary care physician or emergency doctor, and they have some sort of question or complaint or symptoms that needs investigation. And if after the physical exam and the investigation that's done by the primary care physician, there's not yet a concrete diagnosis, very often the next step will be medical imaging. So that doctor will then consult with us in the department in medical imaging and ask for some sort of test. And what we usually ask for is a little bit of clinical history, some background about the patient, and some sort of question to say, what do you think is going on? And what do you think maybe a diagnosis might be? And then they ask us for a certain type of test, and we'll also consult with them in terms of giving advice, looking at all the information they've given us to say, you know what, for the type of question that you're asking us, we think that these are the tests that might be most appropriate to answer your question, because we want to help you come to the right diagnosis based on all the information that you've given us. And then on the day of the exam, the patients will come to the department, they'll interact with our front staff, our booking clerks, booking agents, they'll get prepared for the exam, they'll then meet the technologists. The technologists will explain the exam to them, get them all set up in the various machines that are required, run and perform the exam, and then those images are delivered to us as radiologists, and then we can hopefully come up with some sort of cohesive diagnosis or plan or some sort of idea of what's going on. For the most part, we as radiologists will sit in a computer room where we're presented with a whole bunch of screens in front of us, and whenever the exam is complete, we have the background of the patient's clinical history, we have the clinical information and the diagnostic question that's being asked of us, and then we'll have all of the images that were generated through the various tests, and hopefully some prior tests and other clinical information that's available to us, and then we'll generate a report to give back to the physician that has sent that question to us, and hopefully be able to give them some sort of cohesive answer. So how do we do it? This is the more interesting thing. I mean, like I said, 30 or 40 years ago, we only really had x-rays at our disposal, and that's where the term radiology comes from. But now medical imaging, it's a much more broad term. We have much more advanced technology. Our main modalities that we have certainly are x-ray. We also have CT scans, MRIs, and ultrasounds. And I thought I'd take you through a bit of a tour of those machines and show you what some pictures look like. So this here is one of our x-ray machines. I think we have three upstairs, I can't remember. They told me to take a picture of this one because the room is painted in a nice nautical theme, and I think maybe the kids enjoy this room a bit more as well. Has anyone here had an x-ray? Imagine, yeah, I should probably ask, has anyone here not had an x-ray? Yeah, so this is the pretty basic machine. It's kind of like a camera where you put your target on the detector, and then the technologist will essentially take a picture, and it generates a radiograph or an x-ray image for us. So this is a very typical radiograph or x-ray image. I'm sure many of you, if not all of you, have seen pictures of what an x-ray looks like before. Any thoughts on what part of the body this might be? Yeah, exactly. So if you put your hand up to answer the question, that would be correct, because it is in fact your forearm right here. So this is just what a standard, typical x-ray of the arm looks like. This is also a very classic radiograph or classic x-ray image. Any thoughts on what this might be? Yeah, so this is a chest x-ray, probably one of the most common exams that we do at the department. What about this one here? Yeah, all right. So this is another very frequent one, low back pain. It's a very common complaint and concern, so we'll do a lot of spine radiograms. So again, not to repeat myself too often, but certainly 30, 40 years ago, these are the only tests that were available. But thankfully now we have much more advanced imaging that can give us far more information, and we can look at more than just the simple structures that we see in X-ray. So who has seen this machine before? Who has had the pleasure of being in this machine? That's a good half of you. Any thoughts on what it might be? CT, yeah. So this is actually the same type of technology as an X-ray, as a radiograph, or an X-ray machine, in the sense that it uses the same type of energy to generate images, whereas an X-ray machine, a radiograph machine, shoots in one direction, kind of like taking a picture. In this case, you have the same type of energy source and detectors, but instead of being stationary, you have multiple detectors and multiple sources, and they spin around the patient at 360 degrees. And so if you've been in this machine, you've probably heard the spinning as the detector goes around and around you. And then that bed will slide up and down through the machine as the pictures are going up and down instead of just one spot. So again, it is kind of like an X-ray in the sense that it uses the same technology, but it's much more advanced in terms of how much more we can see. This is the workhorse of the department, I would say. We have two of these machines, two CT scanners. This is our newest, fanciest one, with a lot of advanced capabilities. And between the two of them, just speaking from experience, we can often generate up to 15, 16 scans or studies, and that can be a whole head-to-toe scan, which would count as one every single hour of the working day. So, you know, we had 15 or 16 per hour from 8 to 5 or 7 to 6 o'clock, and then continue scanning throughout the evening and overnight as needed as well. So these generate a lot of information for us, and I would say this is definitely what keeps us the most busy as radiologists and technologists in the department. It can answer most questions very well. It is limited in some functions, but it is definitely a very good first or second line tool for the most clinical questions that are presented to us. So of those that have had a CT scan, have many of you had the chance to see the images? Has anyone seen a CT image before? Yeah. So yeah, this is the ones that we don't get access to the films as easily. You know, I guess before you might actually get the films, you can bring back those X-ray films to see them. But the CT scan is a bit different because whereas an X-ray radiograph will just be 1 or 2 pictures, a typical CT scan might be 150, 250. If we're doing a more complex study, sometimes we can have 1,000 images just to look at in one study. So this is a pretty common one. This is one that we'll do many times a day. Any thoughts on what we're looking at here? Yeah, so this is just a plain CT scan of the brain. And we're looking at it in what's called an axial sequence. So we're just looking at it in as if we kind of slice the top of our head off and we kind of scan up and down the head just like that. What about this here? This is another very common one. Yeah, so this is an abdomen. Do I have a pointer here? Can you guys see the mouse? Is the mouse showing on the screen? Or do I have a laser? So up on the top left of the screen, it's the liver. And then that black stuff at the back are just the bases of the lungs. So it's the same, we're looking at it the same way as we would the head, but this is just through the upper part of the abdomen, just to give you an idea of what a CT scan image looks like. So this is the same technology as an X-ray, but you can see that we get much more information. If we took an X-ray of the abdomen, we would never be able to see the differences between the liver and the spleen and the stomach and whatnot. So a lot more information is available to us here. So I've shown this to you before. It looks a little bit different this time. Yeah, so this is the same body part. This is the lumbar spine, the lower spine that we had in the radiograph. And I'll show you in a few minutes what the spine looks like in different modalities side by side, so you can see the progressive levels of detail that we are able to see. So, is this a CT scanner? No, this is our magnet. This is our MRI machine, if you will. So it looks a lot like a CT scanner, but it works completely differently. How many have had the pleasure of being inside this beast? Okay, fewer. Yeah, kind of makes sense. It seems like everyone has had an X-ray. Most people have had a CT scan, but not as many people have had an MR exam. So this uses no radiation whatsoever. It's a completely different type of technology. It uses a powerful magnet to change the spin of the protons in our body, and then through some complex math, physics, and magic that I don't really fully understand, generates some images which are then presented to us on the screen, and then we can hopefully come up with some diagnosis. Now, a CT scan, like I said, it's the workhorse in the department. It answers a lot of questions very well, and it's a fast test. Like I said, we could generate 15 to 16 of those every single hour between the two machines. Once the patient is on the machine in the CT scanner, we take 30 seconds, a minute, 2 minutes, depending on the type of exam that we're doing. A typical MR exam will take 30 minutes, 45 minutes, up to an hour, depending on what we're looking at. And whereas the CT scan will generate, generally speaking, 1 or 2 different types of images, every type of image that's acquired from the magnet needs to be specified. And so we will generally have 4 or 5 different types of images, whether it's looking from the front or from the top or from the side. And there are different things that you can play with in terms of the contrast, and everyone has to be acquired separately. And that's why the exams take so long. So a standard MRI will take 30 minutes at a minimum. And that's why it's not a very good screening test, because it wouldn't be very efficient. And it's also not very good at answering a lot of questions. A lot of parts of the body that don't have water in them won't give any good images at all. So that's why very often we'll start with an X-ray and then maybe a CT. And then usually we'll save the MRI for much more specific questions because it takes much longer. And it's not very good at answering a number of clinical questions. And part of our job is to triage, if you will, the clinical questions and the type of exams that we're offering to figure out if this is the best use of our limited equipment, to figure out if this is actually going to answer the question and will be of use to the practitioner and to the patient. So, has anyone seen an MR image before? So any thoughts on what this might be? We're looking at something from the front. The shoulder, yeah, this is the shoulder. So we're just seeing the top of the humerus on that side. So we can see the difference between the skin. We go from the outside, the black part outside, you can see the skin, you can see the subcutaneous fat, you can see the muscle, you can see the humerus, you can see the bone. There are all sorts of different structures, and you can see the difference between all the different soft tissues, much more than you would in a CT scan and far more than you would in a radiograph. So we saw a CT scan of the brain not too long ago. This is an MR image of the orbit. So in fact, looking at where the eyes are located, and we get a bit of the brain in there as well. And you can see also we have much more definition in the brain as well. So on the CT scan, you had some degree of definition in the brain parenchyma, whereas here, there's far more detail. You can really see the differentiation between the different parts of the brain quite well. This is a picture of the abdomen. So I showed you a brief one of the CT scan before. This is one of the abdomen, whereas the liver is on top and the bottom of the patient is facing down, just as an example. And then I've shown you 2 of these. This is the 3rd one I've shown you so far. This is the lumbar spine. So just out of interest, I thought I'd show you the difference of the same body part between the 3 types of images that we have, or the 3 types of machines that we have. So on your left is the radiograph, in the middle is the CT scan, and on the right is the MR. And you can see that there are progressive levels of detail. And what I think was interesting and what's worth pointing out is that if you wanted to look at the spinal cord, which is behind the vertebral bodies, you don't have any concept of what that might look like on the X-ray or on the CT scan. But once you get into the MRI images, you can see the spinal cord coming down through the middle. It's that black line behind the vertebral bodies. So if we wanted to look at that part of the body, the first 2 tests don't really give us any information, and we would probably jump straight to the MR imaging, because that's the only one that would give us the right type of information in that case. So this is why when we ask for clinical information, it's really useful, because we can help decide what the best type of test would be. If it's a bone pain, we can go for an X-ray or maybe a CT scan, but if we're concerned about the spinal cord, we know we need MR, because that's the only thing that will show. This is a fluoroscopy. This is our fluoroscopy room. Fluoroscopy is essentially X-rays. It uses at a lower dose. And we use it live in the sense that the operator, including the radiologist, will be in the room at the time of operation of the machine. And the patient will be lying on the bed, or the stretcher in this case. And fluoroscopy is usually used for procedures, interventional procedures. So in our department, we have a couple of radiologists who have undergone additional training in interventional radiology. And they are able to do a lot of procedures which in the past would have required a lot of more intensive surgery, general anesthesia, large cuts, a lot of recovery time. Whereas now what we can do is bring them into the department and under a little bit of local anesthesia, no general anesthesia, often accessing the insides of the body through a small puncture in one of the vessels, perform different operations and procedures that can be done in far less time, far less recovery that would be needed traditionally with general surgery. So an example of that would be this picture right here. If somebody were to come in with internal bleeding, it means one of the vessels in the body is bleeding where it's not supposed to be, and it needs to be stopped, because if not, they'll be very unstable and lead to poor outcomes. In the past, they might have needed general surgery to open up and find out where the source of the bleeding is, and then try to stop it in time. In this case, what will happen is if a diagnosis is made clinically, they go through a CT scan. We can find the source on the CT scan. They'll come into the interventional suite, and all they need to do is be lie down in the stretcher, small puncture site in the vessels, and then through a variety of very complex technical maneuvers that I am not capable of performing, but our interventionalists are able to get to the source of the bleeding, take pictures like this, see what the vessels in the body look like, find it, and then with the tools that they have at their disposal, stop the bleeding. And like I said, all through a single puncture site in the groin. So this is another realm of radiology that has certainly expanded in the past 10, 20 years. Another example, which I'll show you shortly, would be biopsies. Many procedures that used to require general surgery, large interventions, now can be done through a very small access with the use of imaging. Now, general radiologists that haven't had that subspecialty or interventional training also will do interventional procedures. With my training in musculoskeletal bones and joints, I do a lot of interventions with the bones and joints. A common one that I'm sure a few of you probably have had done is to have steroids injected into our joints. You might have contrast injected into your joints if you're going to have an MRI of the shoulder or the hips or whatnot. And we'll often use that same fluoroscopy machine that I just showed you to help us identify the right place and to confirm that we're putting the medication or the contrast into the right spot. So we don't have to do it blindly anymore. We can use the benefit of our nice machines to make sure that we actually are in the shoulder or are in the hip, and we're putting that medication where it needs to be. So this is something that we do on a daily basis in the department. And running through here, this is our ultrasound machine. Anyone here had an ultrasound? I would imagine so. Probably if you were pregnant at some point, you had an ultrasound. And this is a picture of our newest and fanciest ultrasound machine that the foundation has provided us with. The quality of the images now are far better than they were even just 10, 15 years ago. This is a very useful technology. This is, again, completely different than MRI, completely different than X-ray. We're using sound waves to generate pictures in the body and to generate pictures. And what it does is it requires a very skilled technologist, ultrasound technologist, to essentially move the probe over the right parts of the patient's body and change the settings of the machine so that the images that are sent back to us are really what we're looking for. So this is much more operator dependent because it really requires the use of that technologist and that technician to bring the images based on where and how they place the probe and position the patient, as opposed to a radiograph or MR or CT once they're in the machine. It's, I'm not going to say automatic, but it's much more straightforward. Just to show you a few quick pictures of what an ultrasound image looks like. These are some pictures of the liver. And this is a panoramic picture of the side of somebody's leg. They felt a bump on the side of their leg, so we took some panoramic pictures and we could make sure that there was nothing there that was worrisome. This was normal in this case, but this is what an ultrasound picture looks like. It looks completely different from an MR, looks completely different from an X-ray. So in my last couple minutes, I just wanted to show you a few examples of some of the problem solving that we do in our department, kind of what a typical diagnostic or clinical question might be. These are ones that I've come across in the past couple of weeks in my practice. These are ones that I've done myself. And in this case, we have somebody who came, and I think the initial complaint was something like weight loss or some vague complaint that required further investigation. After they did some lab tests and imaging, they found that there was something in the colon, something in the intestines, and then something in the liver. So the next step was to go to their surgeon, and they had a colonoscopy to look for what it might be in the colon, but they couldn't get there. They couldn't find it, or they couldn't get to the right spot. So the only other source, the only other spot in the entire body was this tiny little speck on the liver. And as has probably been discussed earlier today, or you might be aware of, that it's one thing to make a diagnosis clinically, but if we are to proceed with any type of treatment, it's important to have tissue diagnosis through pathology, because certain things may look a certain way on imaging, but if we want to ensure that the treatment is correct and accurate and appropriate, we need to send some sort of tissue to pathology. So as such, radiologists now very often will be performing biopsies to get some tissue to send to pathologists so that we know what the diagnosis is, we're absolutely sure, and then our treatment physicians can then proceed with the appropriate care. So in this case, The patient had complaints. They were presenting with symptoms that were not resolving. They were not able to get to the colon, and so the only spot left was this speck on the liver that needed to be accessed before they could figure out what was going on and what the appropriate treatment was. So in this case, we did an ultrasound. The ultrasound here, the image is a little bit hard to tell. The spot on the liver was right by the diaphragm, so every time the patient breathed, it moved up and down and up and down and up and down. So you're kind of chasing that little spot with your probe, trying to find it. And then sure enough, we were able to find it here. It's highlighted by the arrows. It's a little bit hard to see, but this is one of the reasons why we do a lot of training to make sure that we know we're looking at the right thing. And once we found the spot, we said, okay, we're going to go ahead and biopsy this. And this is something that we do in the department. So the patient's lying there on the ultrasound bed. We position them appropriately, clean the area off, freeze the skin, and then we go in with the ultrasound probe in one hand, the biopsy needle in the other. And because it's the live imaging, because the images are constantly being updated as we move the probe, we can see as our needle moves closer and closer and closer to the target. And once we're there and we're sure we're there, fire the needle, and then we can take our biopsy. So it's kind of hard to see on this picture here with this bright line. The biopsy needle, and that's going into the target. And sure enough, symptopathology, come back with a diagnosis, and the patient can go proceed with their treatment. Similarly, just another example with a different modality. Somebody comes in with some chest complaints. They have a scan of their chest, and it shows a large mass in the lower part of the chest. In this case, the patient had multiple previous cancers and other medical concerns. So we see something in the lungs, but we don't know what it is. Was it related to, for instance, a breast cancer? Was it related to colon cancer? Was it something benign, which can happen? For something that big, it's less likely, but can happen as well. And we need to know because the treatment options are very different depending on what the diagnosis is. So similarly, in this case, we use CT. We can use our imaging to help biopsy it, whereas in the past, it would probably require thoracic surgery, going into the lungs, taking out a chunk of the lung, general anesthesia, a lot of recovery. Now we can do this in about 20 minutes. The patient comes in, clean the area, freeze the skin, go in with the needle, and you can see the needle that's at the top there. In this case, we just flip the patient over, they're lying on their chest, and take a biopsy of the lesion, and then we have our answer, and they can go home in the afternoon for dinner. Time-wise. I'll just go through one really quickly here, and then I'll certainly open up to questions. In this case, we didn't do a biopsy, but I just wanted to show you what different things can look like on different imaging technologies. This is a young patient that had multiple lesions in the liver, which is quite unusual for a young patient. It's also quite unusual to have cancer in somebody that young. So we wanted to do multiple imaging tests to figure out what the possibility was or what the diagnosis was before proceeding to a biopsy. This is an ultrasound. Again, it's quite hard to see in this case due to some technical factors, but there were multiple lesions in the liver, which are highlighted here with the arrows. We then did a CT scan, and in the center of the screen here, you can see that there were at least two. There were probably 4 or 5 by the time we scanned them, lesions in the liver. And then we didn't quite have enough information. We had some suspicion of what it might be based on the ultrasound and CT scan, but we wanted to be absolutely sure. So let's use everything we have at our disposal, and we send them to MRI. So as you can see, the quality of the images in MRI is much different than they were in CT scan, and it gives us much different information. In this case, we used a type of contrast agent, a type of dye, which is picked up specifically by liver cells. So if the contrast is there in the lesions in the liver, we know that it has something to do with a liver function as opposed to some other cancer, if you will. So in this case, we put the patient in a scanner, injected the dye, and took images at different time points to see how that contrast reacted. Does it light up early? Does it light up late? Does it hold on to contrast? Does it let go of contrast quickly? All these different parameters can help us diagnose what is going on in there without the need for a biopsy. So in this case, we had a presumptive diagnosis. We'll continue to follow just to be sure, but we were sure enough, and everyone was sure enough that we didn't need to proceed with the biopsy, and in fact, it wasn't anything too worrisome, and we were able to do that all just with imaging, without any intervention. So that's kind of a quick tour of the department. Certainly, if you have any questions, I'd be more than happy to answer them at this point.
Yeah, we'll take questions for Dr. Lee. Any questions?
I just have a question in regards to, there's a lot of companies out there now that are doing MRIs privately, full body, right?
Yeah.
And I just want your take on that, like people are paying enormous amounts of money. Is it beneficial? Is it worth it? Please repeat.
Yeah. So the question is, what are my thoughts on private whole body MRIs?
And they're saying they can detect this and they'll tell you what your
Yeah, it's a bit of a complex answer in the sense. So MRI imaging, I find, is best tailored to a specific question because we really have to generate each sequence and each type of image that we look at to answer a very specific question. And if we don't think of what those sequences might be, it might not give us the right answer because the images will be completely inappropriate. And one of the things that we have to deal with all the time in imaging are incidental findings, things that were picked up just by mistake. Frankly, the vast majority of them turn out to be nothing, but because they've been discovered, they have to be followed and investigated, and those can incur additional costs and interventions and complications that are troublesome. And then also, we see frequently patients that have been scanned for various reasons frequently, and they'll be normal, and then they'll come back 6 months later, 8 months later, and then all of a sudden they've developed cancer or some other type of process. So for one, I don't think there's much benefit in a whole body screen because you don't really know what you're looking for, and it can't give you too much information because it's very broad. You have the risk of picking up stuff that probably won't matter, and it will risk additional complications. And then just because you have a clean bill of health on that one scan doesn't mean that 6 months later everything will be okay. That sounds ominous, but that's I don't think there are much benefit.
They say they've made so many advances in radiology in the last 20, 30 years. What's in the future, do you think? Are they?
Yeah, that's a fascinating. So sorry, the question was, there have been so many advances in imaging in the past 20 to 30 years. What's next? I would say that the main focus of research these days is on artificial intelligence. We're essentially, letting computers, some would say replace, some would say augment us, if you will. And it has to do with all the technologies that we have. I've seen artificial intelligence applications in X-ray and artificial intelligence applications in CT. An example of one that is used regularly now is CT colonography. So if you've ever had a colonoscopy that didn't work, another option is to go in the CT scanner, and it essentially replaces colonoscopy, except that if you find something, you can't biopsy it. The computer will run through the entire colon by itself and detect all of the lesions, and then we have to review them ourselves. So that's something that's done now. In 10, 20 years, I'm sure there'll be a lot of automatic detection. The question is, how accurate will that be, and how much human oversight will be needed? It's a guessing game as to what it's going to look like even 10 years from now.
I forgot. Yeah, they're doing that long ago.
What about functional imaging and CT scan?
Yeah. So functional imaging, we don't get a lot of exposure to that in our training. Functional imaging would be what you see in research. So in MR, for instance, they're looking at different parts of the body light up when people are presented with different stimuli. So they can see what parts of the brain are active. That's one example. PET scan would be another one. I'm not a nuclear medicine physician, so I don't know much about nuclear imaging. It's a very time-consuming study. Like, a functional imaging test might take 1 or 2 hours. And it's usually only done at specialized centers. So I don't think that's ever going to come into general clinical practice. I think that'll just be mostly research. But what do I know? Yeah.
Angiograms, are they part of the one where you go through the groin and go into the heart, or is that a separate?
Yeah, so angiograms can be done in 2 ways, well, 3 ways actually. So our vascular surgeons will often, one of the exams we do very frequently are CT angiograms, where they'll inject dye in the CT machine, and then they'll scan from the abdomen down to the toes, and that lets us see the vessels on our CT scan all the way through the toes. A conventional angiogram is the one that's done on a fluoroscopy table, where they inject dye and they're watching the X-ray screen live, and in that sense they can then actively intervene. So one of the things that our interventional radiologists do on a regular basis are these angiograms, and then if a vessel needs to be opened or stented, they'll do that on the table. And then cardiologists will also do the same thing, same technology, but for the vessels of the heart. And then you can also do MRI angiogram as well. Yep.
Okay. Any more questions? Okay, great. Thank you very much.
Thank you.
Okay, our last speaker, but certainly not least, is streaming in. Brian? So our last speaker of the day is Dr. Pippa Hawley, who's internist by training, an internal medicine doctor, a general internist, and then has specialized in palliative care, palliative health. She's head of the UBC Division of Palliative Care and a medical director at the BC Cancer Agency's Pain and Symptom Management Program. She's active in palliative care research and has co-authored a book called The Lap of Honor, which is a no-fear guide to living well with dying for patients and their families living with serious illnesses. So welcome, Dr. Hawley. Thank you very much for agreeing to speak to us today on medicinal cannabis.
Thank you, Brian. Can I just check, can you hear me okay? Can you hear me all right? Yeah, oh, okay, lovely. And could you also just tell me, is it possible to flip a screen around so I can see who's in the audience or how many are in the audience? Because all I can see is you standing there, and it's difficult when I can't see my audience. Is there any way of seeing them? Do you have an audience camera?
She wants to see the audience. There may be a privacy issue. The IT Fraser Health Department saying there might be a privacy issue. I'm happy to hold up a mirror.
That's okay. That's okay. If you could, roughly how many people are there?
There's 30 people. Yeah, from our community. There's 30 people, and there's about 15 online.
Okay, perfect. Okay, well that's good. That gives me a little bit of an idea.
And the demographic is widespread. I'd say most people are over 40 years of age. Predominantly women, from what I'm seeing, but I'm generalizing. So.
Okay. For advancing the slides, can I do that, or will you do that for me?
Just say next slide. We'll do it.
Next slide. Okay. Okay. Thanks very much. I'll crack on because we don't have a whole lot of time, and this is actually quite a large topic to be covered in a relatively short period of time. So of necessity, it's going to be somewhat brief, but I'm going to try and keep a good 10 minutes available for questions and answers at the end. So if you can just go to the next slide, first of all, just to show you my disclosures. I don't have any financial links. Unfortunately, I wasn't smart enough to invest in the cannabis industry way back. And in actual fact, I'm quite glad I didn't, because then I have to declare it every time, and that would shoot me in the foot in terms of credibility. So the only potential is that I hope to start a medical cannabis extract clinical trial very soon. We're just waiting for final authorization by Health Canada, which works at glacial pace. But the product that we're going to be using has been donated for free, but I do all that in my spare time and don't earn any money from it. So if you go to the next slide, this is what I quite like to cover if we have time. I'm going to just discuss the medical issues with medical cannabis, what it is and how we think it works. And then I'm going to talk a little bit about the sort of legal aspects of it and how to access it. But remember that my perspective is one of an internist, and I've got an oncology-based practice. So I know this is a cancer-based presentation today, the day, but I won't be able to answer a lot of questions about its use, for example, in harm reduction, or about the consequences of recreational use, or for use in situations that are not similar to cancer or survivorship issues for cancer patients, just because that's not what I do, so I wouldn't be credible in that. I have colleagues who could talk to you about that. So next slide. This is just you don't have to remember all the neuroanatomy here, but the aim of this is just to demonstrate that the cannabinoid receptors are active in everybody's bodies, that they're normal. As you sit there in the audience here, there are natural cannabinoids coursing through your veins, and without them you wouldn't exist. that they're necessary for us to live and to reproduce. And they're very widely distributed throughout the body. And there's essentially two types. There's the CB1 receptors, which are primarily in the nervous system, and the CB2 receptors, which are in the next slide. But if you can have a look at the distribution of the CB1 receptors throughout the brain, the darker green means the higher density of CB1 receptors. And you'll see that they're fairly evenly distributed through the center of the brain, and somewhat in the cerebral cortex, but lightly there. And they're particularly dense in an area of the brain at the base called the cerebellum, which is the sort of bit that looks like two sprigs of broccoli sticking out at the bottom. And those are responsible for balance. So it's important to know that different parts of the brain will respond differently to stimulation, and the cannabinoid receptors are selectively distributed through the brain. The one area of the brain that's really pretty clean of cannabinoid receptors is that white stem that's going up the middle. Looks like the stalk on the broccoli. And that brain stem is actually where our brain's receptors sit for respiratory drive. And this is quite different from where opioid receptors sit, which are very densely populated in the brainstem. So the reason for mentioning this is because you can't kill somebody even with a massive overdose of cannabinoids, because there aren't any receptors in the brain that will respond in a way that it would stop somebody breathing. So the only exception to that would be in children who are much more prone to side effects. But in adults, you can't really kill somebody with cannabinoids. So it's very reassuring from a safety perspective, and it's a contrast to opioids. Next slide, please. The CB2 receptors, which I mentioned earlier, are the ones that are a bit more diffusely distributed throughout our body's immune system. But they're also in the brain, but instead of being in the neural tissues, they're in the glial cells, which we used to think were just a sort of matrix that hold the real functioning neurons in place so that they could interact with each other. But it's in the last few years, it's been realized that these glial cells are actually really important. And they have very powerful anti-inflammatory effects when stimulated. For example, if somebody has a road traffic accident, has a head injury, or has brain radiation, or has surgery for a brain tumor, or has brain metastases, these CB2 receptors that are on the glial cells seem to be particularly useful in that we can manipulate them to try to reduce inflammation in the brain. There's also a number of other effects that they can have, and these are just examples to illustrate the ubiquity of the CB2 receptors. There are some people who are born with a genetic defect in the CB2 receptors, and they get accelerated osteoporosis. So cannabinoids are even involved in our bone development and maintaining our bone strength. The thing that makes the CB2 receptors a little bit difficult to study, actually the CB1 receptors as well, is that we're not just born with a set of them that we're then stuck with for life. The receptor activity and the receptor numbers actually as well can be changed when somebody has an infection or an injury or inflammation from one of those other causes that I mentioned. So this whole endocannabinoid system that we have, where we have our receptors and our cannabinoids that we make naturally through our bodies, it's like this constantly balancing system, which is called endocannabinoid tone, and it responds to keep us healthy at times of stress. Next slide, please. So then we get onto the manipulation of the endocannabinoid system, because humans over the millennia have really developed this into a fine art. You can see how long ago people were talking about this. Next slide. When you see a lot of the advertising for medical cannabis, you always see the picture of the leaf. And that's actually not where the majority of the cannabinoids come from. The cannabinoids from Cannabis sativa and Cannabis indica, which are the two main strains of cannabis plant that is used for medical purposes, they have flowers on the ends at certain times of their growth cycle. And those flowers have these little things called pistils, which have tiny hairs on them. And if you look very closely at this picture, you'll see that each hair has a coating of oil, and there's actually droplets of oil that form on these pistils. And this is actually where the highest concentration of the cannabinoids come from. There are some cannabinoids in the leaves and the stems, but they're different to the cannabinoids that are in the pistils. Next slide. So we talked a little bit about CB1 and CB2, but there's also this another sort of dichotomy in medical cannabis that it's important to know about. And this is for the manipulation of the endocannabinoid system, in that we have THC and CBD, and both of them interact to an extent with CB1 receptors, and CBD reacts more with the CB2 receptors than the CB1s, but essentially both of them work together. THC on its own will have one effect, and CBD on its own will have another. But when you put them together, it's not just a little bit of that and a little bit of that. They actually do things differently when they're given together than when either one of them are given alone. So it's almost three things, one, and two. So the THC is the main product which causes euphoria when people take it. And over the years, the use in religious ceremonies and in trying to experience euphoria, the humans have genetically sort of selectively bred cannabis plants that make a lot more THC than CBD. And even over the last 10 years, this has accelerated hugely. So some of these new cannabis strains can produce really high levels of THC. But it's very complicated, and the CBD alone seems to actually moderate the effect of the THC on the receptors, as well as having its own effects. And CBD alone has only very recently become available to study. There is a product which is probably going to be made able to be sold in the US in the near future, called a PDLX. And the PDLX is going to be used as an anticonvulsant, mainly for children. Some of you may have heard of Charlotte's Web, which is a medical cannabis product made by a company that became very famous in Colorado. There was a little girl called Charlotte who they developed it for. And this is really where the interest has come from. So if anybody has an interest in looking at the effect of CBD on epilepsy, just Google Charlotte's Web, and you'll see a couple of TV shows about her, documentaries. Next slide, please. So I mentioned the endocannabinoid tone. There are some conditions that appear to be caused by dysfunction of the system. Like, we don't all have the same endocannabinoid tone. Some people are very prone to a complex of conditions which seem to be related, like irritable bowel syndrome, fibromyalgia. Chronic fatigue syndrome is probably part of that. Other people seem to have migraine. Some people seem to have cannabinoid excess states where they have symptoms that can be controlled by CBD, sort of blocking the effects of the endocannabinoid system, including schizophrenia. There has been some experimentation with looking at cannabinoid blockers for obesity, thinking that, well, if people consume THC and they get the munchies and put on weight, maybe if you block the effect of the endocannabinoids, then people will be able to lose weight. In actual fact, unfortunately, though that does work for losing weight, it also messes up a whole load of other systems in our body. So the treatment is not tolerated well at all. CBD seems to be particularly useful in affecting this endocannabinoid tone. It's a little bit different in choice of conditions you would treat if you choose something that has more CBD in as a product, as compared with if you want to treat something else where you'd need more THC. So next slide, please. So as of 2018, in October, when they legalized access to recreational cannabis, this was a huge change. And unfortunately, whenever Health Canada has made a legal change to cannabis access, they've created unintended consequences. And at the moment, it's really it's not been good for medical users, because a lot of people were not able to access the legal plant-based medical product from licensed producers because it was only from in the mail. They were much more comfortable going to a walk-in dispensary. Most of the dispensaries were reasonable, but some of the dispensaries were not. They were not really safe places to be. But when they created the legalization legislation, it effectively shut down a lot of these walk-in dispensaries. And although in the long run, that'll be a good thing because they weren't properly supervised, they weren't, the products weren't tested, and there was no accreditation or training for the staff. Some of them actually did provide good service, and there was a gap between closing them all down and having enough access to the good quality product that's tested and pesticide free, mold free from the licensed producers. And that gap meant that there was a bit of a dip in availability, and some people weren't able to access it. So a lot of people are still using the illegal products from unlicensed dispensaries, or even worse, from a friend. And some people grow their own at home. And you may think, well, what's wrong with that? You know where it's come from, but it's actually quite hard to do this properly. And particularly the pests and the molds are a big problem. And if you have somebody who's maybe a cancer patient and immunocompromised, if they're taking a product that has potentially these contaminants, they could make them sick. So next slide, please. This is a list of some of the conditions with claims for benefit, and I've tried to kind of group them by color. I hope this color shows up reasonably well on the screen. The ones in red on the right there are the ones, so this is alphabetical order, okay? The ones on the right are conditions that Health Canada agree that there is sufficient evidence that they are helpful for. So pain in cancer, some non-cancer pain syndromes, wasting in AIDS, though we don't see much of that these days, but also ALS or motor neuron disease, Lou Gehrig's disease. A lot of those patients have muscle spasm, and multiple sclerosis and spinal cord injury. Those are the ones where it's officially allowed to be used according to Health Canada. But there are other conditions that I've listed here, particularly the green ones, where there's actually quite an accumulation of good evidence now to suggest that it can be helpful. And then in the black, these are some that are very promising. There are plenty of patients out there who are using cannabis for medical purposes with these conditions, and they are anecdotally reporting great benefit, but they haven't been properly tested in clinical trials yet. Next slide. So one of the problems with getting things licensed is that they have to go through a rigorous process of study and reviews, and then they have to be reviewed by Health Canada. Those I mentioned earlier work at glacial pace. And the problem with a lot of the reviews of cannabinoids is that they have put all of the research that's been done over the last 30, 40 years and put it all in together. And sometimes in the earlier days, the products that were being tested have very little actual THC in and virtually no CBD. The actual balance of the cannabinoids in the products was not actually reported, so you don't really know what they were taking. It was just labeled cannabis. A lot of them use fixed dosing schedules as well, so they would have the Health Canada supply, which was a poor quality product that was the only one that people allowed to buy from Health Canada for a long time. They tested that, and they would make sort of standard cigarettes and put marks on them so that people had to smoke a certain amount at a certain frequency and time interval. And of course, people are all different. We all have different endocannabinoid tone, and we all have different sort of deficits or needs with different cannabinoid substances. So if you make everybody take the same stuff in the same amount at the same time, inevitably there's going to be some people who get a lot of side effects because it's too much, and some people who it doesn't work at all because it's not enough. So using these fixed dosing schedules also grossly increased the reports of intolerance and inadequate effect, much less effective and more poorly tolerated than when people are allowed to select the dose themselves. They also use products that are effectively unavailable. I didn't actually go into detail before on that slide about what products you can get, but there are prescribable products. One is Sativex, which is an excellent 1-to-1 ratio of THC to CBD, which has been extensively studied and shown to be safe and effective. And the problem is that it comes in little bottles which have about 90 squirts in it. You squirt it on the inside of the mouth, and you can only buy them in packs of 3, and it costs $700. So it doesn't matter how wonderful a product it is, if it's going to cost you $700 just to try it, I think that pretty much makes it effectively unavailable. And there is also a prescribable product called Nabalone. Its trade name is Sesamet, but that's not even a plant-derived cannabinoid. It's a THC synthetic equivalent. and it really has all of the problems that you get with just unopposed THC that doesn't have the CBD. So the drawbacks of many of these studies and reviews is that the administration routes are also not recommended. They're mostly about smoking because we haven't had ready access to extracts until very recently. So just reading these studies and reviews is not always very helpful. And if you go to the next slide, please. The other thing is that there's not a lot of clinical trials that have been done recently, and this is not through lack of trying. It's one of those catch-22 situations where Health Canada will say, oh, we don't have enough evidence, so we can't make any recommendations, but then they'll prevent you from actually doing the research. So this is very difficult research to do. The trials are not easy to do in a traditional randomized controlled trial design. We know that the dose-response relationships are not linear, meaning that a little bit might work a little bit, and then a bit more might work stronger, and then a bigger dose might cause side effects. It's not that simple. There are sort of sweet spots where you can get to a certain point, particularly with anxiety, where a little bit of THC can relieve anxiety. But if you go higher dosing, you can actually get worsening or loss of the anti-anxiety effect, and in some people actually a worsening of anxiety, and people can even have psychotic episodes if you give them too much and they're not used to it. So taking one compound and testing it in isolation is also something which medical researchers like to do, and the regulators like to see that every compound is tested in isolation. But as I mentioned earlier, with medical cannabis, that whole construct is invalid because the different cannabinoids have evolved over the millennia to work together, and that you don't see the same effects in plant extracts as you do if you take out these individual components. And essentially it's made it effectively almost impossible to do medical research with cannabis, certainly in Canada. I've been working on this clinical trial for over 5 years now, and we still are only getting close to being able to start. And it's really very frustrating. So just next slide, please. A little bit about BC cancer patients. Just as by way of background, we did a couple of surveys, 3,000 surveys mailed out, 800 responses mailed in, which is actually not bad for a general public mail-out survey. This is all the patients who had attended for a BC cancer appointment on an index day in January. It was a Wednesday in January. And this was first administered just before recreational legalization, and then we repeated it again afterwards. And this is the before legalization survey, and you can see some of the results there. Half of the people that responded had used cannabis at some point, and half of them were currently taking it. So if those 800 that responded are representative of BC cancer patients generally, that means about a quarter of cancer patients are taking cannabis. Most of them that were currently taking it were looking mostly for symptom relief, though there were quite a significant proportion that were also using it to treat cancer. And I have some concerns about that maybe we can talk about if we have time in the discussion, because there really isn't any evidence that that is helpful, and it could potentially be harmful. There were also a very small number who admitted that though they took it primarily for symptom relief for cancer, they also did derive some recreational benefit from it. So it was a bit of a gray area, and you couldn't always necessarily separate them into medical or recreational users. And then we repeated the survey again after recreational legalization, but there was a lower barrier, and a lot more people had actually admitted to thinking about trying it because it was less stigmatized. But sadly more reported the challenges about accessing the appropriate products. Next slide, please. We did a different survey, actually, just surveying people who were using it for symptom relief, and they reported these side effects. So these are quite common. Dry mouth is in about 50%. Sedation, a bit dose dependent, but a lot of people found the sedation to be helpful because they were using it primarily for sleep disturbance. Some people did get dizzy with it, particularly those that took more THC than they had time to get used to, and it can drop the blood pressure. So people who have a tendency to dizziness or have an unstable cardiac problem, that would not be a good choice for them. Interestingly, a lot of people said, I don't know if anyone else has noticed it as well, but my tummy is rumbling really loudly. And it was frequent enough that that is something that we warn people about. And it's probably something to do with the effect it has on the bowel, which is mild constipation. We also have a number of patients who've become confused from taking it in excessive doses. So again, if someone has a history of confusion or psychosis, we would be very reluctant to suggest it. Another group that is quite prone to the side effects of cannabis is the youth, children and youth who have a developing brain. And we would definitely not encourage use of high doses of THC in people under the age of 25. We do know that high doses can cause a problem with cyclical vomiting, though that's rarely been reported in the medical context. It's just something that people need to be aware of if they're trying to use high doses to treat cancer. If they start vomiting, it actually may be the cannabis that's doing that. And there are a few interactions that we need to worry about. The main one is an antipsychotic called clozapine, but there are a number of other medications which may interact weakly. One of them is anticoagulation with warfarin. People often need a little bit of minor adjustment of their warfarin dose. And then the last thing is you have to be careful about exposure to anything which can affect the immune system if you're actually on an immune therapy where you want the immune system to be working strongly. We don't really want an anti-inflammatory, because that inflammation is hopefully what's killing the cancer cells from your immune therapy. So people that are on immune therapies, we would recommend at this point that we don't use them. Lastly, last but one slide here, I just wanted to show you what a sample website entry might look like for a product that would be what I would see as an ideal. This is as close as you can get to Sativex, the one that's actually licensed for use, that's the $700 for the prescription. So this is a licensed producer, that's what LP stands for, licensed producer derived oil, and it's a 1-to-1 ratio between THC and CBD. And each one of these these little bottles is about $150, that's 60 mils. So depending on how much you used, this is a moderately concentrated one. This might last you 2 months. So just to give you a rough idea of budget there. And then the last slide. So just for the take-home points, I want you to be aware that there is some quite good evidence for cannabis products that are already available, but we do definitely need more research, particularly on CBD, which is being very widely advertised and sort of made to sound as if it's like THC, but without the psychosis. But that's really not the whole story. We do need a lot more information about this because so many people are spending so much money on it. In my experience with cancer patients, the magnitude of benefit may be small in the majority, and not everybody responds, but some people do really well with it. And particularly for those that tolerate traditional medications poorly, or they don't find to be effective, I think everybody should have an opportunity to at least try it. There are mild adverse effects, which are quite common, but in general, the safety profile is actually pretty good. Certainly quite good in comparison with opioids or drugs like tricyclics or gabapentin, which are commonly used for neuropathic pain. And I find that medical cannabis does really quite a good job with neuropathic pain. There are groups of people that we would want to be very careful with, particularly the young, those who have mental illnesses or unstable cardiac problems, and people that are on concurrent immune therapy. And if you are thinking of trying medical cannabis, I would definitely say go to a licensed producer online and go with a 1-to-1 ratio of THC to CBD oil, preferably to start with. If you're nervous about the effects of THC or you've had bad experience with recreational use in the past, then go with an even lower proportion of THC and go with a more CBD predominant one. And as with all medicines, when you're titrating against effect, you need to start low and go slow, and more may not necessarily be better. There may be a point where a low dose is just right for you. And if there are clinical trials that you are eligible for in the future, mine hopefully being one of them, I would really encourage you to participate. And with that, I think we're done, aren't we? Yes, we are. So we can go to questions.
Thank you, Dr. Hawley. We'll open it up for questions. Any questions? Go ahead.
Okay, and I'm just going to open up the chat function as well, so that if anybody wants to ask the question, they can also use the chat function on the online.
Go ahead.
What
what do you mean by unstable heart condition?
The question is, what do you mean by unstable heart condition?
And so an unstable heart condition would be somebody in whom a drop of blood pressure might cause problems for them. So somebody who perhaps had heart failure and was on a lot of medication for that, including water pills and other medications to stop their blood pressure. The other situation would be somebody who has a history of angina. Maybe they was having angina on a daily basis and having to use the nitroglycerin under the tongue. Those would be the two conditions where I think we'd have to be quite careful. I would definitely go with the very low THC variety as well as before. Or with a more of a CBD product and start with the low dose and go for the not an absolute contraindication. It's not you can't use it, it's just you need to be a bit more careful.
Another question is, can we measure cannabinoid states in the body? Is there any?
Yeah, wouldn't that be nice? I mean, it is technically possible, and that's how they've done these studies, but you have to actually do a lumbar puncture and take cerebrospinal fluid and send it to the lab to test it. And that's not a whole lot of fun. So it would only be done in a research context. It wouldn't be justifiable to ever do that in a clinical capacity. To get the same answer just by trying a bit of medical cannabis to see what it does to you, that would have just the same way of telling us what you're under the cannabis.
She's cutting in and out. Is there?
Yeah. Am I cutting in and out?
Yeah, a little bit. Another question? The question is personal, if you've ever used it.
Oh, actually, I have tried it myself for arthritis. I have osteoarthritis, and it doesn't work for me. I've never tried it recreationally.
I have a question, Dr. Hawley. My understanding is that the cannabinoid component is about 120 molecules of different cannabinoids. So with Sativex and Epidiolex, which are credentialed now by Health Canada and FDA respectively, how do we know that the level of CBN or CBG, CB whatever is the same from one vial that the child is getting in Alabama is the same as the child getting it in Michigan? How do you confirm with botanical extracts that they're actually the same? We all take a medication, or many of us take a medication, but it's one molecule, right? Your Crestor, your Lipitor, and so forth. It's all one medication. We're used to one molecule when we take a pill. This is an extract of 120. So how do we patent or credentialize these?
Yeah, so actually, just in terms of the sound quality, it just made me think with the background noise, maybe if you turn off your, if you mute yourself, that might stop me cutting in and out. Hopefully that works. So that is a very good question. And it comes up a lot, always from doctors, often from pharmacists, who are very uncomfortable with the uncertainty of not knowing exactly what they're prescribing for people. But at the end of the day, what really matters is, does it work? The testing and having all of their products properly tested and having all of their different multiple cannabinoids actually able to be looked at really helps, because you can it's not just about the THC and the CBD. As you mentioned, there are all these other cannabinoids as well. For example, you can have somebody perhaps with migraine who can have two different extracts, one from one licensed producer and one from another, with exactly the same THC to CBD ratio, but one will work much better than the other. And that's probably because of the myrcene or the limonene or one of the other terpenes there. So if somebody can try something and say, well, this one seemed to work well for me, this had a lot of this, maybe when I'm looking, if I can't get any more of this, I need to look for something else that looks very similar. So you kind of just have to change the way that you think about things, and just work with the products that we have available. I mean, as long as you know what you're taking, eventually we'll figure it out. Like at some point, maybe in 10, 20 years, when we've had an opportunity to actually test these things, there will be combinations which are able to be produced in factories where they take all the cannabinoids out of the plant, separate them out, and then put them back in a fixed ratio combination. I guess you could do that, but then nature's kind of figured that out over the last millennia. I'm not sure that we need to mess with it. You can unmute yourself now.
It must present a problem with research, because you may be doing research on one botanical extract from one LP, which may be different from another LP.
But at the end of the day, you got to start somewhere, and most of them are actually fairly similar. Like there's not a whole lot of differences between them, especially if you balance the THC and the CBD. If you standardize those, the rest is definitely worthy of further research. There's so much more we have to do, but that shouldn't stop people feeling comfortable using it now.
Another question is, are there side effects to smoking marijuana?
So two points on that. First of all, when you're talking about it in the medical context, please can you not use the term marijuana? Okay, that was a term that was invented by the Americans to stigmatize cannabis users. Okay, and so you're just playing the game of stigmatization to use that in a medical context. So just expunge that from everybody's vocabulary in the room right now. Okay, if you're talking about teenagers and smoking cannabis recreationally, then that's the context, the only context where the term marijuana would be really appropriate. Even then, I have my doubts. But if you could just try and think of the word cannabis in preference. And sorry, that was a bit of a hobby horse of mine. So just tell me what the question was again.
The question, are there side effects to smoking cannabis?
Oh yeah, so the smoking, yeah, yes. I mean, the side effects of smoking anything, and if you smoke cigarettes, you smoke tobacco, it's going to give you a cough, and it might give you lung cancer, it might give you tongue cancer, throat cancer. There's a whole lot of nasty things that can happen. Makes your fingers go yellow. I mean, it's all the same stuff. It's not the nicotine that's the problem in the cigarettes primarily. That's just the addiction. All the rest of the side effects like COPD and they're all a result of all of the cellulose and other bits of junk that you have to smoke to get the nicotine out of it. And cannabis is just the same. There's a whole lot of stuff that you have to expose your lungs to that shouldn't be exposed to extract the cannabinoids from them. So definitely we don't recommend anybody smoke it. That's why I don't even talk about the dry plant product. I talk about the extracts only. So I definitely encourage people to only use the extract if possible.
I've heard it can accelerate vasculopathy. I'm not sure if you've heard any.
No, I've not heard that, but I must say, I mean, there's no reason why it wouldn't, because smoking cigarettes does. I would say, though, that the risk from smoking cannabis as compared with smoking tobacco is substantially less. And that may not be because the inhaling, burning bits of plant product from whatever it is. I mean, you could burn rosemary or, I don't know, dandelions. I mean, if inhaling anything that you shouldn't be breathing in is going to cause problem to your lungs. The thing is that smokers tend to do it 20 or 40 times a day, whereas cannabis smokers tend to do it much less than that. Many people who smoke cannabis do it occasionally in an evening or once or twice a day. So the overall accumulated exposure to the products of combustion is much less with cannabis smoking than with cigarette smoking. But again, this is very hard to tease out because there aren't large populations where we've got 30 or 40 years of separate cannabis-only smokers and tobacco-only smokers and being able to compare the two. They're very different demographics, and so they may not be comparable in other ways. So I don't think we're ever going to get really, really good data on that. But so far, the epidemiological data suggests that the risks of getting lung cancer and having COPD from smoking cannabis are actually extremely low. That does not mean I recommend it. I recommend against it.
Another question is cannabis in any form addictive?
Yes, anything that can lead to euphoria can cause addiction, but people that are taking medical cannabis, especially if they're taking it either with the oil transmucosal or swallowed, the onset of effect is so low, and because people are not seeking euphoria, they're actually just trying to be normal. The risk of getting dependent on cannabis for medical purposes is really very small. Again, I'm not talking about recreational use, that's very different. High THC inhaled, yes, the potential is there for dependence, and it's probably around 10% of heavy users can become actually dependent, get withdrawal symptoms when they don't have access to their substance of choice. But again, I wouldn't say that that would be of any concern to me if I was prescribing it or authorizing it to somebody to manage, for example, chemotherapy-related peripheral neuropathy, where all they want to do is be comfortable. Like that, when there's no euphoria, there's no dependence.
Okay, Dr. Hawley, thank you so much for joining us today. It was a real pleasure.
You're welcome. Thank you to everybody for listening. Sorry I can't see you.
Okay, look, so thanks for joining us today. I really want to thank all the speakers for taking the time outside their busy schedules and their families, and the organizing committee, Tracy and Liz and the foundation, as well as you all for attending, and also to our sponsors. So hope to see you next year. If you can send us some comments. Do we have? Yeah, there's a feedback form in the handout in the agenda. If you could leave that, that'd be very helpful. We use it to formulate our talks next year. And yeah, have a great day. Thank you. That was, well, the only thing